Welcome everyone. Today we'll be discussing about nephrology, followed by we'll be discussing about urology. So we're discussing two topics today, so it might be a slightly longer session today. In nephrology, we are talking about kidneys. So the first thing we'll be seeing about is the acute kidney injury. There's two classifications which you need to be aware of. One is acute kidney injury staging. Another one is Rifle's criteria. They're quite similar, only few changes are there at the bottom. At this level, there are few changes. Otherwise, they're quite similar to each other. Okay, stage one, or in Rifle's criteria, it is known as risk. When there is serum creatinine level increased more than 1.5 times of its baseline, or serum creatinine is more than 26.5 micromoles per liter, over 48 hours, this over 2 days, it has increased so much, or the GFR is decreased by at least 25%, or the urine output is less than 0.5 ml per kg per hour for consecutive 6 hours, then we call it as in stage one or risk in Rifle's criteria. Stage two, or the injury according to the Rifle's criteria, will be serum creatinine at least 2 to 3 times it has increased, or GFR is reduced by more than 50%. Here, urine output is again 0.5 ml per kg per hour, but it is lasting for 12 hours. Okay, it is all what we are looking for. Last one is failure of the stage 3, where the serum creatinine is more than 3 times, or the serum creatinine levels itself are more than 354 micromoles per liter, or acute increase, that is in less than 48 hours, acute increase of more than 44 micromoles per liter, or GFR has decreased or reduced by more than 75%. Then you are looking at the urine output also is another criteria to look out for. From emergency point of view, we are mainly looking for the creatinine. Sometimes in rare conditions, you might look at the urine output where you are able to measure it. For example, someone who is on catheter and there is no urine, or there's only decreased amount of urine which is there since last 6 hours, then you can calculate and see whether it is less than 0.5 ml per kg per hour or not. In that way, you can quantify it and see. Otherwise, mainly in emergency department, we are depending on the creatinine levels. The last stage is only in the Rifle's criteria, where there is complete loss of kidney function for 4 weeks, more than 4 weeks. That is basically there is no urine output at all. On renal, on need for renal replacement therapy for more than 3 months is known as end-stage renal disease. Why is it important? It's important to know the stage 1, stage 2, stage 3, or this initial part. Why is it important from emergency point of view to know the staging? You should know more than staging. You should know when the patient is going into an acute kidney injury. If he's in stage 1, or according to Rifle's criteria in risk category itself, that means this patient has lost or the function of 50% of the nephrons that is present in the kidney have been lost. That's when you see 1.5 times increase in creatinine. So there is a drastic difference. So the kidney function has reduced drastically. Then only you see 1.5 times increase in the creatinine level than the baseline. That means this patient all requires an admission. You can't just discharge him. You need to take this seriously. To make you understand why it is so serious, that's why our CM likes to know you or wants you to learn about the staging, because just an increase by 1.5% itself means that there is a quite significant injury to the kidneys, which are set in already in stage 1 itself. There is quite significant injury. What are the causes for acute kidney injury? We are just worried about acute. We are not talking about chronic. So we are in emergency. Acute is the thing for us. Acute kidney injury causes can be divided as pre-renal, that is before the kidney, mainly the blood supply to the kidneys. So something is wrong here. So the blood supply to the kidneys is reduced. Why? There is an hemorrhage and blood loss. There is a acute dehydration, like for heat stroke. There's an sepsis which is causing third spacing of the fluid, or there is an ocular occlusion, for example, renal artery occlusion, which is not supplying enough blood to the kidney. So there is a failure of the kidney. So these are the pre-renal causes. What is intrinsic? Something wrong inside the kidney itself. So something which is causing injury to the tubular necrosis, like drugs like NSAIDs or aminoglycosides. Something which is causing glomerular nephritis or injury to the glomerular or inflammation of the glomerular, or something which is causing interstitial nephritis, like NSIDs and penicillin. You can see here NSIDs can cause tubular necrosis as well as acute interstitial nephritis. Coming to post-renal. Post-renal is anything which causes an obstruction to the flow of the urine from the kidney. So what can cause? Bilateral ureteric calculi can cause. Calculi or the stricture in the urethra can cause. Compression of the urethra from enlargement of the prostate, like benign BPH, benign prostatic hyperplasia, or because of in cancer, the CA prostate can cause it. So that kind of like phimosis also can cause it. So anything which causes obstruction of the flow of the urine from the kidney, from this kidneys, then it will cause an post-renal acute kidney injury. So we know there are basically pre-renal, intrinsic renal, post-renal. So if you know what is the mechanism, you can reason it out in the examination. If they ask you whether it's a pre-renal or renal or post-renal, shouldn't be a problem. You need not by heart everything. Investigations. One investigation creatinine is to look out for is this patient is in AKI or not. Once the patient is in AKI, it can cause electrolyte abnormalities, increase in urea. Rest of the blood investigations are mainly to look out for the cause. What is triggering it? Is it an infection which is triggering it? Or is it an obstruction which requires a scan? Or is it an heart failure? A significant reduced ejection fraction from the heart will supply significantly reduced amount of blood to the kidneys. So the kidney functions also reduces. That is known as cardiorenal syndrome. It's very difficult to treat it because most of the heart failures we treated with furosemide, where kidneys are already injured or they are in acute kidney injury, then there is no urine output, then furosemide will not work. So it is a very tricky situation. Again, this is more for medicine people, not for us. Blood gas. Blood gas is also an important because acute kidney injuries can cause metabolic acidosis. Metabolic acidosis, which is not corrected by medical therapy, is an indication for going ahead to dialysis. Okay, and urgent dialysis will be required. So we'll be seeing in further slides when and all we need to get a dialysis done. What treatment can you do? As such, you need to look out for whether it's a pre-renal or post-renal cause. Renal cause, you can't do much unless you can just stop the culprit which is causing it. So if you know the cause, treat the cause. Otherwise, nothing much you can do for the kidney injury, what is happening. So you know it is in fluid dehydration, severe dehydration, then you fluids. It's a drug which is causing it, stop the drug. It's an obstruction. If you require, catheterize the patient. Catheterization is also helpful to monitor the urine output. If there are any complications like hyperkalemia, pulmonary edema, which is caused by acute kidney injury, treat it accordingly. Treat the precipitating factors. Whatever precipitating factors is it the obstruction? Is it a sepsis? Is it a drug which is causing it? Then stop the drug. So you're just treating the underlying cause. When to refer to a nephrologist? Most of the time, we don't refer to the nephrologist from the ED itself. It's the acute medicine people who will refer them if they're not able to handle it. So it is not very important to know when to refer the nephrologist because most of the time, half of the reports will not be available in the ED. So you know it's an acute kidney injury, requires a further evaluation. So you'll be admitting under the acute medicine. So acute medicine will go through, evaluate this patient and see, and they will see if there is something which requires specialist treatment, like this patient is having a vasculitis, glomerulonephritis, interstitial tubulointerstitial nephritis, this kind of thing they'll be looking for. There is an acute kidney injury, no clear cause after thorough evaluation. It's not responding to the treatment what you're giving, or there are complications like an hyperkalemia which is not getting resolved with the medical treatment, or it is already in stage 3 acute kidney injury. That means an impending dialysis might be required. Anyone who is on renal transplant, he's already on an renal transplanted kidney, he has it. So it's a precious kidney. So involve the nephrologist as soon as possible. Anyone who already has an chronic kidney disease stage 4 or stage 5, they're basically in almost there for the dialysis. This before the end stage renal disease, they are almost in the peak. Any insult like this will push them for the dialysis. So you will require the nephrologist so that they can come in and intervene and start the dialysis. This is very important from emergency point of view. From till now, what we did learn, AKI classification, then what we can do, treat the underlying cause. So causes for AKI, treat the underlying cause. the important thing is when to do an emergency dialysis. Renal replacement therapy from emergency point of view is dialysis. This also includes peritoneal dialysis. We are just talking about hemodialysis here. Hemodialysis is the preferred one in emergency basis. So we always get an hemodialysis done. It's much easier and simpler intervention than getting a peritoneal dialysis or thinking of any other renal replacement therapy. The main ED indication for initiating an hemodialysis are resistant hyperkalemia. Okay, the severe hyperkalemia, more than 6.5, severe hyperkalemia, you're giving the treatment, all the medical treatment, but not responding. Pulmonary edema, not responding to the medical treatment. Pulmonary edema, what you do? Every patient gets in furosemide, but this patient may not have the urine output, then you will require an dialysis. Metabolic acidosis, you treated the underlying cause, still in metabolic acidosis, requires an dialysis, especially when there is a severe metabolic acidosis. In certain severe poisoning, dialysis is preferred, like methanol, ethanol glycol, or aspirin, or lithium toxicity. Dialysis is preferred. Complications of urea, high urea levels. What is urea? Urea is basically a byproduct of proteins which is excreted from the kidneys in the urine. So it is excreted from the kidneys in the urine. If kidneys are not working, urea gets accumulated. Urea is a toxin for the body. So once this urea gets accumulated, it causes inflammation, and inflammation in various spots. It can cause pericarditis. It can cause encephalitis. So basically it is causing inflammation. So uremic encephalitis this patient can have. So uremic related encephalitis or uremic related pericarditis or inflammation of any other organs might be an indication. Most of the time it is an indication if it's a pericarditis or encephalitis because of acute kidney injury and because of high urea levels because of acute kidney injury. So this completes acute kidney injury. Now we are getting into rhabdomyolysis. Muscle breakdown of the muscle fiber is known as rhabdomyolysis. How does a breakdown of the muscle fiber occur? It might be because of trauma and an electric shock, compartment syndrome, involuntary movements, increased involuntary movements like drugs, which can cause this one, like cocaine, ecstasy, statins. Rhabdomyolysis is one of the important side effects of statins. Prolonged seizures or prolonged exercise or prolonged immobilization. This is important, immobilization. Most of them forget. If an elderly person who had a fall and unable to get up from the floor for a long time, then he might have had an rhabdomyolysis, which can cause an acute kidney injury and various other complications. Okay, that becomes very important. Neuroleptic malignant syndrome or malignant hyperthermia, all this can cause rhabdomyolysis. So what is the clinical sequelae? So rhabdomyolysis, so we have an muscle fiber which is broken. Once this muscle fiber is broken, the potassium is going out. Okay, so there will be increased level of potassium in the serum. Calcium gets deposited on the broken. Along with it, even the fluids gets deposited or gets sequestrated inside the muscle fiber. Along with potassium, there is also a release of phosphate. Phosphate is important. There is also release of phosphate from the cell into the serum. Okay, there will be increased phosphate level, increase in potassium level, decrease in calcium levels, decrease in fluids. That is nothing but hypovolemia. So we will see an hypovolemia. We will see increased phosphate levels will eventually result in metabolic acidosis. Okay, these muscle fibers are excreted in the kidneys. So it gets stuck in the kidneys and causes tubular necrosis or tubular nephritis, resulting in acute kidney injury. Can result in DIC also. So any patients who comes and complains that I was lying down, I had a syncope, I was on the floor for a longer time, and I noticed that my urine is dark in color. Anyone who says urine is dark in color, just don't think it's because of dehydration. It might be because of excretion of myoglobin. Always get a dipstick done in all of these patients. Investigations, we are looking for the electrolyte abnormalities, we are looking for the kidney functions. Okay, those are the important things what you're looking out for here. Okay, CK levels are very important for the diagnosis purpose. Okay, if CK levels are more than 3 times the base level, then we call it this patient might be having an rhabdomyolysis, but it doesn't correlate with the prognosis. Okay, usually CK CK is creatinine kinase, creatine phosphokinase. CPK, we call it creatinine phosphokinase. It might be elevated 2-3 times. Sometimes, usually it is in 100, so it might be around 1,000. Sometimes it might be 10,000. Sometimes it might be a lakh. Doesn't mean that there is a poor prognosis or it doesn't correlate with the prognosis at all. It is required for the diagnosis, not for the prognosis purpose. Management. The mainstay of this treatment for rhabdomyolysis is fluid resuscitation. You give fluids, that's it. You can't do nothing much. What about bicarb and mannitol? It was used previously. There is only one study which shows that giving sodium bicarbonate and mannitol might be helpful, but latest recommendations in UK, and if you see in that internally also, they recommend just fluid resuscitation is the choice of the treatment. If the patient is not responding for fluid resuscitation, where you're targeting an urine output of very high, that is 200 to 300 ml per hour you're targeting, still the patient is not responding, or the acute kidney injury is still there, you're not able to achieve the urine output what you're having, then directly go ahead with renal replacement therapy. That is nothing but hemodialysis, what you need to do in these cases. That finishes our rhabdomyolysis. If anyone has questions regarding the AKI or rhabdomyolysis, you can ask me now.
Dr. Amin, sometimes these, I think so, bodybuilders who are taking proteins and they're just coming with high CK levels, no other abnormalities in electrolytes and these RFTs. So still we have to do this we have to give fluids and like that. Even patient is
They will have
asymptomatic.
marginally high CK levels. If you see them, they will be having, your upper limit usually will be 200. It depends from lab to lab. There might be 2 times the upper limit. Okay, we are talking about 3 times the upper limit to really think about rhabdomyolysis. That's why we say 3 times the upper limit. They might be marginally high. Even you run for a certain distance and get your CPK done, it will be slightly on the higher side. So it is not indicative of an rhabdomyolysis. It should be at least 3 times more.
So protein intake can raise this CK levels?
Protein levels, protein intake as such will not cause. If someone is taking a protein supplement, will not increase the CPK levels. Urea levels will increase, that's a different thing. But here, rhabdomyolysis doesn't happen. Usually it happens because of the vigorous exercise what they're doing. Nothing much, you need to just advise them to take plenty of fluids. They should be fine. No need to evaluate for them.
Okay, thank you.
Dr. Amin,
yes, please.
ED presentation from the patient with rhabdomyolysis. What is the goal of management in the ED?
Fluid resuscitation.
Fluid resuscitation.
Doing fluid resuscitation, and we are admitting this patient. Looking for whether this patient requires a renal replacement will be usually seen after admission. In ED is difficult to see unless this patient is already in stage 3 AKI where there is no urine output. You're giving fluids but no urine output, he's going in fluid overload, then you need to admit this in ICU to get dialysis done on an emergency basis.
Okay, but predominantly treatment is fluids.
Fluid, yeah. No bicarbs. What you need to remember is fluid is the mainstay. If fluid is not working, I will go ahead with the dialysis. There is no role for mannitol. There is no role for bicarbs.
Bicarb and mannitol, no role. Thank you.
No. So we'll go ahead with hyperkalemia. Again, very important. Hyperkalemia, they tend to ask you questions either on the treatment per se or on the ECG. So those are the 2 favorite things what they'll be asking about on the hyperkalemia. So first we'll be seeing what are the causes for hyperkalemia. Sometimes it might not be a true increase in potassium levels in the serum. It might be a false reading. Why doesn't false reading happen? The sample, if you keep it outside for a longer time, it is not in citrate solution is not there, then it might lead to hemolysis, breakdown of the RBCs. Or you are using a tourniquet tied very tightly, that can cause hemolysis. Or a sample is taken from a limb where you're giving a potassium supplement for this patient in the IV form. Again, it can present as an increased or given false reading of high potassium levels. In this, usually we go ahead and we just repeat it. Okay, don't get confused in the examination. If a patient is completely fine, clinically doesn't suggest you of an hyperkalemia at all, but lab results suggest 7.1. Okay, ECG is fine, everything is fine. Don't just go ahead and start treating this patient. Just repeat and potassium level before you think of treating this patient. That is important. They'll test you, because it is not, if someone has in 7.5, he'll have symptoms. 7.1, he's having a severe hyperkalemia, he will have symptoms. He doesn't have any symptoms. ECG is fine, everything is fine. This usually happens in UK because GP would have gone routine blood investigations. In routine blood investigations, potassium has shown high. GP will say, go to the emergency department. They come to the emergency department. The first thing what we do is get an ECG to make sure this is not a true value. If there are ECG changes, we'll start the treatment immediately. If there are no ECG changes and the patient is completely asymptomatic, then we just repeat it and ask him to wait till we repeat the potassium values and make sure that it is in the normal range. It's in pseudo hyperkalemia what this patient is having. Easier way to remember the actual causes of hyperkalemia is to see what is going on. Intra to extracellular shift. So something from inside is going outside. So potassium is inside, it's going outside. What can it cause? Acidosis. If there is lots of hydrogen ion, it will get exchanged with the potassium ion which is inside the cell, so that the pH is maintained in the normal range. Heavy exercise. Heavy exercise is nothing but rhabdomyolysis, what we are talking about, and we know why there will be high potassium levels. Insulin deficiency. What is the work of the insulin? The work of the insulin, other than obviously to maintain your glucose levels, is to push the potassium inside the cell. So we use it in the treatment also. So if there is decreased insulin levels in your body for any reason, it can cause high levels of potassium in your serum because it's not pushing it. Similar function is carried out by other drugs also, like beta blockers, suxamethonium, what we have already done, digoxin toxicity, potassium overload. So what is potassium overload? How is it happening? Either it is because of breakdown of the cells or increased intake. One special thing what you need to remember here is GI bleed. Okay, exactly mechanism is not known why GI bleed causes increased potassium levels, but it is one of the important causes what you need to remember. Most of the people tend to forget here. Decreased potassium excretion. It is excreted by kidneys. So some injury to the kidneys will cause decreased potassium excretion. So it might be AKI. All the causes of AKI might result in high potassium levels because of decreased secretion. Sorry, decreased excretion, not secretion, excretion. What are the clinical features? You need not remember all this. You have to just remember that he will have weakness. Okay, there is this weakness and there will be loss of reflexes. So he might complain of some muscle weakness, paresthesia, hypotonia, areflexia, ascending paralysis. Along with this, you will be having GI symptoms like nausea, vomiting, diarrhea. So grossly remember, it's a muscle weakness along with loss of reflexes, nausea, vomiting, diarrhea will be there. Main thing is they will have ECG changes because potassium is very important for the cardiac muscle to work optimally. So once potassium levels are high, you start seeing the ECG changes, what have been described here. The first change what you see is peaked T waves. Later on, you go on seeing other changes like PR prolongation, bradycardia conduction abnormality, sinusoidal rhythm, that is nothing but widened QRS complex with bizarre QRS morphology. Okay, I'm going fast here because we are already discussed in our ECG class regarding this one. So these are the peak T waves, what we are seeing here. These are the peak T waves. Sorry, okay. These are the peak T waves, what we are seeing there. So there are many ECG changes, sinusoidal rhythm, the ECG and all we have discussed already in the ECG chapter. They are important. Next thing important other than the ECG changes in hyperkalemia is the treatment part. When it is mild, this definition for mild, moderate, severe changes from source to source what you're taking. This is mainly from ALS and Oxford Handbook of Emergency Medicine, what we have taken from. Stands good for UK, so just follow this one, don't break your head. Okay, some books give some other classification, don't just follow this one, what we are given you. If it's mild, you're just planning to excrete more potassium in the form of calcium resonance, or you can give sodium sulfonate, or you can give furosemide. You are not that bothered about if it's mild. Okay, you can just admit them and not start this treatment in the emergency itself. Someone else will start the, or you can, is completely fine. You can even plan to discharge him if you know the cause for hyperkalemia and ask him to follow up with the GP. But most of the time we'll admit them so that we exactly evaluate why there is an hyperkalemia and treatment can be given. Moderate. If moderate is there in ED itself, we give a mixture of insulin and dextrose. The mixture is usually 10 units of short acting. Preferred short acting is human actrapid. Along with it, you are giving an dextrose. That is nothing but a sugar so that it doesn't cause hypoglycemia here because you're giving insulin. This is infused over 15 to 30 minutes. 50 ml of 50% dextrose mixed with 10 unit of human actrapid infused over 15 to 30 minutes. In severe, that is more than 6.4, salbutamol will be giving. We usually give around back-to-back 3 nebulizers that will be 15 mg. Along with it, we are giving insulin as described previously. Along with it, we'll give soda bicarb if there is acidosis. If there is acidosis only, we will give soda bicarb. Otherwise, soda bicarb is not indicated. Okay, in all other. Next comes is ECG changes. When ECG changes are there, then only we give calcium chloride or calcium gluconate. Also, you can give as an alternative to calcium chloride. We give it only if there is ECG changes or the patient is in cardiac arrest. Otherwise, don't give calcium chloride. Rest of the 3 management is similar to that of the severe for ECG changes. In cardiac, nebulization is not practically possible. That's why we are giving rest of the 3 treatments. We are not nebulizing this patient. Why do we give only if there are ECG changes calcium chloride? We know, or you must have studied from your pharmacology, that it stabilizes the cardiac muscle and prevents arrhythmias. Why not give it when it is severe itself or moderate itself? Because the duration of action of an calcium chloride what you're giving is a very short lived. It's around 5 to 15 minutes. Okay, it doesn't last for a very long time, the cardiac stabilization what it is doing. So when there is an ECG change, you can give it. If you just give it as in prophylactic, it doesn't work, or it's not helpful at all here. In cardiac arrest, why do we give it? We know that it might have affected the rhythm of the heart. That's why the patient has gone into cardiac arrest. So we are giving the calcium chloride to reverse the effect what it might have caused. Next point, at the last one, is few people have confusion whether I need to give calcium chloride or whether I need to prefer calcium gluconate. Both have similar efficacies. The calcium 10 ml of 10% calcium chloride is equal to 30 ml of 10% calcium gluconate. The strength, the amount of calcium what is there is same. If both are given in the options, calcium chloride, you need to pick it up because it's an smaller dose, what you can easily push it over 2 to 5 minutes. 30 ml pushing through IV, it takes time, it takes a little bit more effort. So calcium chloride is preferred in that way. Otherwise, the efficacy and amount of calcium what is available is equal in the both. Okay, there is one is not superior than the other one. That finishes hyperkalemia. Now we are into hypokalemia, reduced potassium levels. So it might be because of gastrointestinal loss like seen in diarrhea, or you might have used certain drugs, especially the diuretics like furosemide, laxatives, or adrenaline if you have used. Renal loss. Renal loss mainly because of renal tubular acidosis. That's diabetes insipidus, or during dialysis also there is loss of potassium. Endocrine causes, hyperaldosteronism, nothing but Conn's disease. The opposite of Conn's disease is Addison's disease. Addison's disease causes reduced potassium. Addison's disease causes high potassium levels. Conn's disease causes low potassium levels. They are exactly opposite to each other. These are 2 endocrine abnormalities what we'll be studying in coming up classes. As metabolic acidosis causes hyperkalemia, exactly opposite mechanism causes hypokalemia. For example, in metabolic acidosis, there is exchange of hydrogen ion to the potassium ion from inside. So this is going from inside to outside. That's why there is hyperkalemia. What happens in alkalosis? The hydrogen ions are less. So the potassium is pushed in and the hydrogen ion from intracellular space is taken out into intravascular space. Okay. So this potassium levels have gone down because of metabolic alkalosis. Last one, but the most important one is hypomagnesemia. What is the importance of hypomagnesemia? Hypomagnesemia itself causes hypokalemia. But if there is reduced magnesium sulfate levels, magnesium levels, if you give potassium for the correction also, it is not effective. It will not show increase in potassium levels. It will be resistant to the treatment. That's why always correct first magnesium, then only correct the low potassium levels. So what are the clinical features here? So again, weakness, constipation. Here, constipation. There you saw the diarrhea in hyperkalemia. In hypokalemia, it is constipation. Rhabdomyolysis, ascending paralysis can be seen. U wave, T wave, flattening. ST segment elevation is given in your notes, which is wrong. It is a depression, what you commonly see. Arrhythmias and AV systoles. Again, we have discussed about hypokalemia. We'll quickly have a look here. This is basically ST segment depression with T wave inversion. This is the U wave, what you're seeing here. Okay, it is in ST segment, sorry, this one is more clear. ST segment depression, this is the U wave, what you're seeing here, along with T wave inversion, what you're seeing. So how can you remember this ECG changes? It is pushed down. That's why it causes ST segment depression with T wave inversion. The upward notch, what you're seeing is nothing but U wave. It's not a T wave, it's a U wave. In hyperkalemia, you see the peak T wave because you're pulling it up. That's how you can, mnemonic wise, you can remember it like this. Treatment per se. Okay, the maximum in a person who has come to the emergency department, what you can transfuse is 20 millimoles per hour. Okay, each ampule comes in 20 millimoles. You can transfuse 1 ampule over an hour's time, not faster than that. Only in certain circumstances you can give fast. For example, in cardiac arrest. In cardiac arrest, the same dose can be given over 10 minutes. If it has not come back to the normal range, then you can give 10 more minutes over 10 millimoles over again 10 minutes, half of the dose over 10 minutes. In pericardiac arrest, 10 millimoles over 10 minutes can be given. Okay, these are the special circumstances where you can infuse the potassium at a much faster rate. Otherwise, the standard recommendation is 20 millimoles per hour is the fastest what you can do, otherwise slower. Always requires a cardiac monitor when you're transfusing the potassium. Okay, cardiac monitor should be there because potassium what you're giving itself can trigger arrhythmias. Magnesium, always check for magnesium. If there is hypokalemia, you need to do correction for magnesium before you do an potassium correction. What if potassium is severely low and magnesium is also low? You can simultaneously correct both of them. Okay, never give potassium only. It will not be effective. It will be resistant to the potassium correction because of low magnesium levels. Hyponatremia, that is low low sodium levels. There are various causes for low sodium levels. Okay, there are various methods to go about it. The most standard method is first you'll be seeing the serum osmolarity. If it is normal, we have certain causes. If it is high, we have certain causes. Most of the time, serum osmolarity will be low, that is less than 280. If it is low, then you are assessing clinically the volume status, whether it is hypovolemia, euvolemia, or hypervolemia. Hypervolemia is because of failure of one of the important organs like heart, kidneys, or liver. In hypovolemia, first thing you'll be looking out for is urine sodium levels. If there are less urine sodium levels, that means the kidneys are trying to retain the sodium. What it is excreting the kidney is not less. It might be because of dehydration, diarrhea, or vomiting. If kidneys is excreting more, then there is something wrong in the kidney itself because kidneys are excreting more of the sodium. It might be because of diuresis, or it might be because of some mineralocorticoid deficiency, or it might be because of cerebral sodium wasting syndrome. Last one is euvolemia, where the volume status on clinical examination is fine. So 3 main causes you need to remember here. It might be because of hypothyroidism, syndrome of inappropriate ADH secretion, SIADH we call it, or because of psychogenic polydipsia. That means he has some psychiatric issue where he's drinking a lot of water. Drinking a lot of water will cause dilutional hyponatremia, and it causes increased urine excretion also because your body physiology is normal, but he's drinking a lot of water because of some psychiatric issue. That is known as psychogenic polydipsia. It is not very important, This will be important if you're working in an emergency setup where the patient stays for a longer time, then it might be important. Otherwise, usually questions don't appear on that. Questions usually appear on the treatment per se. There is no classification for hyponatremia as severe, moderate, or mild hyponatremia. Okay, so low sodium levels are not classified as severe, moderate, or mild, or nothing like that, like potassium. The symptoms are important. So in any patient where sodiums have dropped down drastically, that means have dropped down in an acute span of time. They have dropped down in 24 hours, or we dropped down in 48 hours. We're talking about in hours. Then this patient will develop CNS symptoms. Okay, potassium is all cardiac, sodium is all CNS. So what symptoms? If the patient has an seizures or altered sensorium because of low sodium levels, then you need to start the correction in the emergency department itself. You start the correction with 3% hypertonic saline, 150 ml, you give it over 20 minutes, then send for serum levels and give one more bolus and check. If they have increased by 5 millimoles, then when they're good. If they're not increased, then you'll be giving a boluses of 150 ml, 3% hypertonic saline till it increases by 5 millimoles per liter. This is for anyone who has presented with seizures or altered sensorium. That is important, what you need to remember. If they are not presented with seizures or altered sensorium, you are not giving any treatment. You're just admitting this patient. You can just start a normal saline. If the patient is dehydrated, depending on the fluid overload status, then you emergency role ends there, and the acute medicine people will take over and see the cause and treat the underlying cause. So you have to just treat the underlying cause. You're not giving hypertonic saline if there are no CNS symptoms. Hypernatremia. Just remember, hypernatremia usually occurs because of dehydration. So there is loss of water from intravascular space that will cause concentration of all electrolytes, mainly the sodium one. So the sodium levels will spike up. Most of the time it is loss of the fluids. So it might be renal loss of the fluids because of diabetes insipidus, skin loss because of an heat stroke or exhaustion or burns, GI loss because of diarrhea, or it might be some other endocrinal abnormalities like primary aldosteronism or Cushing syndrome where you see it. So what is the treatment, what you are doing here? Okay, most of the time what you are doing, this patient is dehydrated, you will just give a normal saline and just admit this patient. Once the patient is euvolemic, because all the causes what we have discussed is because of dehydration, this patient is having hypernatremia, so we are giving fluids. Once they have reached an euvolemic state, that's when you can plan to give an 0.45% saline, that is 0.5% of normal saline, or you can give glucose. That will help us to further reduce the sodium levels. Do not reduce the sodium levels faster than this, otherwise it ends up other CNS complications will end up. How to calculate free water deficit is a formula you need not remember, not required from the exam point of view. Okay, whatever you are calculating needs to be given over 48 hours, still not required from exam point of view. Serum sodium levels needs to be monitored every 2 to 3 hours. So in summary, you need to remember that hypernatremia happens because of dehydration. Because there is a dehydration, I am giving fluids till the patient comes back to euvolemia. That concept you need to have it, otherwise there will be nothing much asked in hypernatremia as such. So high sodium levels, that nothing but it is because of dehydration. That's why I am giving normal saline. This is what you need to remember from exam point of view. Before we go into calcium, calcium changes and pathophysiology, what is involved in hypo and hypercalcemia, you can ask me any questions if you have regarding hyponatremia, sodium abnormalities, or potassium abnormalities, hypo or hyper.
Dr. Amin, is there any role for urinary fractional sodium? Urinary
You
spot
can use
sodium
it that also. As I told you initially, there are many other methods to diagnose what is the cause of hyponatremia. This is one of the methods commonly used one, what we have put it across. You can use other methods also to diagnose. Urine osmolality, you will be checking. Urine sodium levels, you'll be checking. All those needs to be checked. Usually what we do is we'll send for serum osmolality.
Yes, sir.
Usually what we'll be doing is we'll be sending for urine osmolality, serum osmolality, and serum sodium levels from the ED itself, and it will be followed up with the emergency, followed up by the acute medicine people. So this is one of the methods what you are given. Again, questions will not come on this. Mainly questions will be on the treatment per se and the symptoms what they present with.
In case of hypokalemia treatment, when you correct the magnesium, and in which form you give?
Anyone who has low magnesium levels, you need to correct it. You can't correct potassium without
according to measurement, yeah.
Anyone has low magnesium levels is less than the normal range. If they have low, you correct it. If they are in the normal range, you're not doing anything.
In the form of magnesium sulfate, as they know?
Yes. Usually we give 2 grams of magnesium sulfate.
So if both levels are low magnesium, low potassium, which one do you treat first?
Magnesium.
Okay, thank you.
In case of hypokalemia, that came with DKA, Dr. Amin. Should I correct rapid correction for potassium?
Potassium, you don't give it rapid correction as clearly mentioned here. You only do rapid correction only in cardiac arrest or pericardiac arrest. Otherwise, you're not doing a rapid correction of low potassium levels. It's a slow correction. Either you can do it orally also if it's an, for example, 3.5 is the below 3.5, we call it as a low. If it's only 3, you can just give potassium oral supplements here. You need not give IV supplements at all. Okay, if you're planning to give an IV because it's less than 2.5 is the one where you start giving IV correction. But again, this will be done over and longer time. At least you're giving 20 millimoles over an hour's time. That's the fastest what you can give. Okay, otherwise if you give at a very faster pace, you can trigger arrhythmias in this patient. That's why we don't give it on a faster infusion rate.
Was this cardiac arrest and pre-arrest according to ECG changes, huh?
Cardiac arrest is already in arrest. You don't get any ECG changes we can see here. Pericardiac arrest, who is about to get arrested, who has agonal breaths, he can arrest at any point of time. Then he can push 10 millimoles over 10 minutes. That is just before cardiac arrest, we call it as a peri-arrest here. So we are not seeing the ECG here. We're just seeing the potassium levels and the clinical status. Cardiac arrest means there is no central pulse, there is no response, there is no respiratory no respiratory efforts at all. That means he is in cardiac arrest.
In case of hyponatremia, Dr. Amin,
yes,
it is important to focus it is acute or chronic hyponatremia because there is different in flow and replacement.
Yes, that's why I told you if it's an acute only, you get the symptoms. If it's a chronic one, you'll not get the symptoms. Again, do you know acute or chronic by just looking at the lab values? Unless they got it done a few days back, you'll not be knowing whether it is an acute thing or it's a chronic thing. The symptoms, what you need to look out for. The acute symptom, what you're looking for is whether the patient has seizures or low GCS. If having seizures or low GCS, there is altered sensorium, then you go ahead and treat them. No, then you just admit them.
Okay, thank you.
Good evening, sir. Just couple of 2 questions. I wanted to know in the case of CKD patients who has come to emergency department with the neuroglycopenia and his potassium level is 6, can we still go ahead with insulin? It's quite a difficult situation in that situation. So that's question number 1. And question number 2 is in the case of hyponatremia and 150 ml of bolus of 3.3% NaCl, can we give it in the peripheral line or do you definitely need a central line for it for correction, sir?
Ideally, you need a central line to give an 3% saline, but again, large bore cannula around 18 or more than 18 or less than 18 gauge. If you have a peripheral line, you can still give it in the peripheral line itself. Or if you're having an EJV, you can give it through an EJV. It's not a must that you need to have a central line because it's a painful thing, patient, and it is predisposed to thrombophlebitis if you're giving it through a peripheral line. Coming back to a patient with an high potassium levels in a CKD patients, usually the baseline itself will be around 6. So you don't treat them as per se for CKD patients. We're just talking, all the classification is mainly we're looking for an individual who doesn't have a chronic kidney disease. One, persons who have a chronic kidney disease, usually we don't treat them unless they are symptomatic. What we do, chronic kidney disease is there, he'll be on dialysis, we just shift them for the dialysis, which will get corrected. Okay, a patient who's supposed dialysis to be done tomorrow, he comes today and you check and his potassiums are 7, but ECG will be normal. There will be very good capacity to tolerate the high potassium levels. Especially the CKD patients have good capacity to tolerate the high potassium levels. What we do is we just shift them to get an dialysis done instead of giving any treatment in the emergency department. Again, it depends clinically, you need to take a decision. If there are ECG changes, then definitely you'll go ahead and treat them. It's quite unsafe to give calcium, especially in a CKD patient who doesn't have any ECG changes. It can trigger arrhythmias. Okay, it has happened. If you give it a little bit on a faster pace, whose kidneys are not working because they have high potassium levels, then it can trigger arrhythmias. So you need to be very careful in CKD patients. The simpler way, if you're worried about high potassium levels, just give salbutamol. The fastest acting out of all those drugs is salbutamol. Again, remember that whatever treatment you're giving, the insulin and dextrose infusion, the salbutamol, what you're giving, both of this just causes transient decrease in potassium. After a few hours, if you check it, it will be high again because you're just pushing this inside the cells. After a few hours, it will come out of the cells. It's a transient response or the transient treatment what you are giving. It's not actually you're reducing the potassium levels here. Anyone, any other questions before we go ahead?
Should we give the sodium bicarbonate first in or any like insulin or glucose, like
if required, you can give push sodium bicarb, no issues. If you're giving a cardiac arrest or if you're giving because of hyperkalemia, you can give 50 ml 8.4% push. Coming to calcium. Calcium is closely monitored by parathyroid hormone. Parathyroid hormone is the mainstay of management of calcium levels. Whenever the calcium levels in your serum goes low, that's when parathyroid hormone gets triggered. Once it triggers, it secretes parathyroid hormone. It acts at two places, one at the kidney level, one at the bone level. At the bone level, it causes increased reabsorption of calcium. That's why the calcium levels will come back to the serum and serum calcium levels increases. What does its role on the kidney? This stimulates for the conversion of vitamin D into an active form of vitamin D. It's not important to remember exactly 25 hydroxy, all those things not important. So from inactive form to an active form, it converts. This active form will have an increased absorption of calcium from the gut. So eventually there will be increase in calcium levels in the serum. So that's the role of parathyroid hormone. So what happens? There might be a primary, so something wrong with the parathyroid hormone itself, which is causing increased secretion of parathyroid hormone. That will cause increased in calcium levels and decreased in phosphate levels. In CKD, exactly opposite of it happens. Kidney functions have come down drastically. What happens here if the kidney functions have come down drastically? So there will be reduced levels of calcium and increased levels of potassium will be seen. It is opposite to the primary parathyroid hormone. Secondary parathyroid hormone occurs, or what I explained here is secondary parathyroid. That is, first there is reduction in calcium levels, then the parathyroid hormone is triggered, then the parathyroid hormones are secreted. That is known as secondary parathyroid hormone. Thus, the reason the calcium levels might be low or have been come back to the normal. It's normal physiological effect what we are seeing here. Okay, vitamin D. Vitamin D is required for absorption of both calcium and phosphate from the gut. If there is low levels of vitamin D, both calcium as well as phosphate, both will come down. Both these levels will come down. This is very important from your exam point of view because they tend to ask questions there. Let's see first low levels of vitamin D. In children, they present more drastically compared to that in adults. In children, we call it as an rickets. In adults, we call it as an osteomalacia. Both causes brittle bones. Both are prone for fracture because of brittle bones. In children, what happens? The bone strength has been reduced, so there will be bowing of the long bones, especially the femur. This is called bowing of the bones, what you're seeing here. How do we treat this? By giving vitamin D supplements. So no other thing you need to remember. Just remember that both these conditions causes brittle bones because the calcium levels have come down in the bones. At the same point of time, they are predisposed for fractures. In children's, it is more predominant or more drastically they present because of the bowing of the long bones, especially the femur. In children, it is known as rickets. In adults, it is known as osteomalacia. So that much should be sufficient from exam point of view because it's not emergency related. Hypercalcemia. Hypercalcemia, what is the most common cause? It is because of primary hyperthyroidism. Second common cause is malignancy. Third is mainly the drugs, what you're talking about. They present similar to high glucose levels. For example, it presents with polyuria, polydipsia, similar to diabetes. The additional symptoms are important. What are the additional symptoms here? Bone pain is important. There is an depression or confusion or anorexia that is important. Abdominal pain is important. Abdominal pain can also be present with an hyperglycemia, like an DKA presents usually with an abdominal pain. So we need to look out from the stem of the question, the bone pain, and some depression, confusion, or anorexia is there. That will help you to differentiate between hyperglycemia and hypercalcemia. ECG changes, one of the important ECG changes is shortening of the QT interval. Other one is Osborn wave. This is Osborn wave. The downstroke of the QRS complex, you see the slurring here, that is known as Osborn wave, also known as J wave. Okay, it is opposite to that of the delta wave. Osborn wave is not specific for hypercalcemia. It is also seen in hypothermia. So remember that it's also seen in hypothermia. When are we treating, or how do we treat these patients? Usually we are really worried if it is severe. Mild or moderate, we are not that much worried. Mainstay of the treatment is hydration. You start hydrating, you start giving IV fluids, followed by you're giving a loop diuretic. IV fluids followed by loop diuretics, because if you just give loop diuretics, this patient can go into dehydration. So you need to start hydrating them, then give loop diuretics. This is the main ED treatment. Mainstay of ED treatment is hydration followed by loop diuretics. Whether to give bisphosphonates, whether to give calcitonin, yes, it is in treatment for hypercalcemia, but rarely, if not ever, we usually never start bisphosphonates or calcitonin in the emergency department itself. What we are doing is we just hydrate them, then give loop diuretics. They are the mainstay of treatment in the ED department. Hypocalcemia, so low calcium levels. So there is no thyroid, parathyroid gland itself. It has been removed because of a surgery or because of some reason, or a CKD patient, or an acute pancreatitis where the calcium goes and gets deposited over the pancreas, or rhabdomyolysis where breakdown of the muscles have caused for the calcium to get deposited over the myocytes. Hypoparathyroidism, calcium channel blockers, or hypomagnesemia. Hypomagnesemia can cause hypokalemia or hypocalcemia also. So all of these causes for hypocalcemia. What are the clinical features? Clinical features are very important because they present with certain classical features. Low calcium affects the neuron. It will cause tetany. What is tetany? Involuntary muscle contractions. He might just show, doctor, see this particular muscle is just contracting on itself. I don't know what is happening. What is Chopstick sign? When you just tap on the cheek, there is contraction of the cheek muscles as shown in this pic. There will be contraction of the cheek muscles. Chopstick sign. What is Stroger's sign? When you just inflate the BP cuff, there will be carpal pedal spasm is seen. These are the classical features what you can come across in low calcium levels. Other symptoms like muscle pain, abdominal pain, perioral tingling also can be present. But these are the important signs. In the stem of the question, they might give you the description of this sign. For example, when I was checking BP, suddenly there was contracture seen in his hand. suggestive of an carpopedal spasm. Most likely this patient is having hypocalcemia. ECG changes, there is prolongation. Mainly you need to remember there is prolongation of QT interval. There is prolongation of QT interval. In hypercalcemia, there is shortening of the QT interval. Those two things you need to remember. We are not worried if it is mild or moderate, we are not worried. If it's severe, that's when we are worried. Severe, remember the value less than 1.9. Then you need to give calcium correction with ECG monitoring. This calcium is similar to that one what we talked about in hyperkalemia. That is 10% of 10 ml, but given over in longer duration, given over usually an hour's time, not pushed like 2 to 5 minutes what we talked about in hyperkalemia. We're given over a longer duration you'll be giving. The dose is similar to what we talked about in hyperkalemia. So here what we are trying to demonstrate is the prolonged QT interval. If you see here, the method what I had taught you in the ECG, these are the two QRS complexes, R wave we have drawn here. Imaginary line we are drawing in between. So the peak of the T wave comes towards the dorsal or towards this one, towards the right side. That's why it looks, or we can presume that it is in prolonged QT interval. Also, if you can just see it, it looks more than 50% of the RR interval. So it must be prolonged QT interval. So grossly, you can easily guess it in the examination by seeing this one. Anyone has questions, you can ask me before we go ahead with the recall questions of nephrology. Then we'll be going ahead with the urology chapter.
Yes, please, sir. Can you repeat the treatment of hypernatremia?
Hypernatremia, you're just giving fluids. Why does hypernatremia happens? Because of dehydration. So you need to correct the hydration, what is there, dehydration, what has happened. So you'll hydrate them by normal saline. Once this patient is in euvolemic state, that's when you think of giving 0.4% saline, 0.45% saline. This is usually done by acute medicine people. We are just worried about dehydration. We are giving normal saline.
Sorry, another question. And treatment of hyponatremia.
Hyponatremia.
When can I give the...
As I told you, we are just looking for seizures or altered sensorium. That's when you treat it, otherwise you don't treat it. Okay, you're looking for seizures or altered sensorium. There is no mild, moderate, severe hyponatremia. It's the duration. Has it happened acutely or has it happened chronically? It's very difficult clinically to know unless a blood test was done a few days back itself. Then you can compare it and say, okay, it has dropped acutely. So how do you clinically diagnose? By the CNS symptoms. Mainly we are looking for seizures or altered sensorium. If this is present, then we will correct it with 3% saline. Otherwise, we'll just admit them so that further evaluation can be done to find out the cause of hyponatremia. Otherwise, no treatment is required from the emergency point of view.
Okay, thank you.
Any other questions before we go into the question and answers?
Dr. Amin,
Yes,
in hyperkalemia, we have to give sodium bicarbonate 50 ml, or we need to calculate the base deficit according to that.
We just give it 50 ml. Why is there acidosis? So there is a mechanism what is going on. So you're just giving 50 ml of 8.4% bicarb. So basically bicarb you're giving is sodium bicarb what you're giving, 8.4%, 50 ml what you're giving.
We don't need to calculate according to base deficit.
No, we are not trying to get the pH back into the normal. We're trying to acutely get the potassium levels on the higher side.
Okay, thank you.
Okay, because pH is low, we're trying to push the potassium levels as soon as possible to the higher side.
Dr. Amin, regarding hyperkalemia, is referred by GP, the lab value is wrong. Also, the patient is asymptomatic. Also, the lab value of the emergency department is high, but the patient is asymptomatic. What do you do? You admit it or discharge it?
So if I'm not wrong, your question is GP has referred because there is high potassium levels and your cross-checked potassium levels are normal. If they're normal, we are just discharging them because they're not the true value what they had in the initial test. If you find it, if it is high, then you need to treat it.
Asymptomatic, patient asymptomatic.
If asymptomatic also, high potassium levels, you need to treat it. Okay, depending on the levels, you need to treat them. Potassium levels needs to come. If it is now asymptomatic, in few hours, it might become symptomatic, this patient.
Oh, thank you.
So let's go into the question and answer session here. The nephrology chapter, what you're talking about. We have a 7-year-old boy who has presented to the emergency department. He is an Ethiopian. He has a low calcium, low phosphate, and low vitamin D level. What is the most likely diagnosis here?
Rickets.
Rickets. Okay, the right answer is rickets here. Let's go for the next question here. We have an elderly male who has presented with complaints of hematuria since last 1 week, denies any burning sensation or increased frequency of maturation. On further questioning, bleeding is noted towards the end of maturation. No similar complaints in the past. Most likely cause.
CA bladder.
Why do you think it's a CA bladder?
Painless hematuria.
Painless hematuria and the end of the maturation.
Old age.
Elderly patient.
That's true. Old age, painless hematuria, you need to always think about CA. Okay, again, depending on what part of the stream of the urine you are noticing, you can have differential diagnosis for that one. Okay, let me discuss more about it. Just a second. Just 1 second. See, if it can be an urinary tract infection, unlikely in this scenario, mainly because urinary tract infection will have some other symptoms like increased frequency or burning sensation. They have clearly mentioned that it has been denied here. Renal calculi can cause hematuria, but usually it's not the renal calculi, it's a CA bladder which causes more commonly. BPH, very rarely we come across. Okay, renal calculi, usually they remain asymptomatic, not even the pain they will have. Even renal CA is not very commonly known to cause hematuria. It's the CA bladder which is known to cause the hematuria. So if it is an initial phase, then usually we term it as urethral bleed. If it's towards the end, then it is from the bladder. If it's mixed, then it can be anywhere, that is bladder, urethra, or kidneys. So you can see here they have mentioned it as towards the end of the maturation. Again, it goes in favor of bladder. That's why it is in CA bladder, what we think as most appropriate answer here. So the next question here we are going at is an old male who is a known case of diabetes and hypertension, complaints of decreased urine output and generalized weakness since last 2 to 3 days. Complaints of tooth extraction 3 days back, is on painkillers for the same. Investigation shows high creatinine and high urea levels, likely cause of AKI, acute kidney injury. The painkillers what he had is NSAIDs. NSAIDs are one of the notorious drugs to cause acute kidney injury. So the right answer here is NSAIDs. So we have the next question here. There is a 69-year-old gentleman presents with 2 days history of vomiting and lethargy. He is a known case of type 2 diabetes and a known case of hypertension. Observation shows and respiratory rate of 22, saturations are normal, heart rate is slightly on the higher side, BP is normal, temperature is normal, BM is also fine. You have the lab investigations here. So what do you think is going wrong here? So what's the likely diagnosis?
There is hyperkalemia.
Hyperkalemia with
Diabetic ketoacidosis.
This is a DKA diagnosis, which we'll be studying in next chapter, how to diagnose it, because ketone levels are also high. There is an acidosis, there is an BM of 11, and he is a known case of diabetes. So it's a clear diagnosis of an DKA. But this patient has a very high potassium levels. ECG is normal. So you will be giving insulin dextrose for this patient.
Insulin dextrose.
Ideally, you should have given salbutamol, because it is the fastest to act one. Salbutamol is not given. The next best one is insulin dextrose. So the answer here is insulin dextrose. So we have
Dr. Amin,
patient
in
recent.
the last
Yes, please.
question, I think we should repeat the sample because the potassium very high. I know no ECG changes. Maybe wrong sample.
No, but he
Can't
had
be a
decay.
wrong sample. Why do you think? Why I'm telling confidently that this is not a wrong sample? Because the pH has come down. Okay, there is something seriously going wrong. This is a DKA patient.
Non-diabetic and hypertensive comorbidity.
Yes.
Use is also high.
Whenever the pH is low, you're thinking as metabolic acidosis. Metabolic acidosis itself is a cause for hyperkalemia. Forget about the diagnosis. Metabolic acidosis is a cause for hyperkalemia. So whenever you're seeing a low pH, it can't be a pseudo hyponatremia.
And also patient have vomiting symptoms. If sample wrong, patient asymptomatic. Here patient is symptomatic.
Yes.
Right?
Yes. Patient is symptomatic. The pH shows acidosis is there. Keeping all this in mind, this sample can be wrong. The patient should be completely normal. pH should be in the normal range. Then you are getting this. Then you can think about. Okay. Again, base deficit and all. If you see here, it's a lot. So we are having a next question here. Patient comes with recently has undergone the thyroidectomy, doesn't remember the reason for the surgery, now complains of oral numbness and abnormal movements. What is the cause of her condition?
Hypocalcemia.
Hypocalcemia is the right answer here. It's a straightforward diagnosis question. A patient known case of CKD presents to the emergency. GP has been recently found to have an hyperkalemia, referred to the ED. No ECG changes in the ED. Repeat potassium levels shows 6.1. What is the appropriate management?
Basically, calcium resonance.
Basically, this is more than 6. So we are thinking in a moderate range. Moderate range, we want to give insulin glucose. One of the options present in this is this one, first one. That's why we are selecting. Salbutamol usually is reserved for a severe case, but again, we want to give insulin glucose, so we are selecting that one. Patient presents
Doctor,
with
why in the previous question you say we take the insulin because there is no salbutamol, and here you choose the insulin and glucose?
Treatment depends on the severity of the hyperkalemia, whether it's mild, whether it's moderate or severe. Here it is moderate, so it is here. What we have learned in the moderate is we want to give insulin plus glucose infusion. There is no insulin and glucose single option available. That's why we are selecting here. In the previous one here, we should ideally have given salbutamol. Why I'm telling? Potassium is 7.3. It is severe hyperkalemia what this patient is having. That's why I want to give salbutamol, which is known to cause or which reduces the potassium levels very fast compared to insulin dextrose infusion. But that is not given. Next best option is insulin dextrose.
Why should you use dextrose? Because patient is already indicate a high glucose level.
Again, depending on the options, we need to select what is adequate here given.
Doctor, if this is in moderate and severe
here,
or
it is
mild,
only 11, it's not very high. Okay. Again, we'll be discussing more about DKA, how to treat it when the levels are 11. How do we give or how do we treat the patients when it comes down to that level? Okay,
Doctor,
usually what we
you
do
give
is
insulin.
Sorry?
In the mild, you give.
No, in mild, we don't give the insulin. We just give calcium resonance, what we give in the mild.
Sir, EC changes not. Sir, EC changes also normal, or it is changes, or there are no changes of modality of management. Both are same, no, sir? EC changes.
No. ECG changes, I've clearly said. No, you have to go through this. You can't get confused here. Okay, there's a clearly a chart what we have made and we have shared here. ECG changes, what you need to do. Cardiac arrest, what you need to do. Severe, moderate, mild. ECG changes are important. It matters to change. Okay, you can't just skip it. It matters to change depending on the ECG changes. If ECG changes are there, you're giving everything, including calcium chloride, you are giving up.
Yes, sir.
If ECG changes are there, does it matter whether it's mild, moderate, severe? No. We're just seeing the ECG changes. If ECG changes is there, we're giving everything, including the calcium chloride. If that was your question. So we're going for the next question here. We have a patient presented with generalized weakness in the last 4 to 5 days with a gradual worsening. GP has recently started on the furosemide for worsening CCF. Lab investigation shows a potassium of 2.1, sodium of 131, magnesium of 1.1, ECG, no acute changes. So what you will be doing in this patient?
Magnesium. Post magnesium supplementation.
Always give magnesium first, followed by potassium supplements. What is the ECG changes? What you're seeing here?
Sinusoidal.
This is known as sinusoidal appearance. Okay, where there is a prolonged QRS complex, tall peaked T waves are seen here. Prolonged QRS complex is seen. It's an pericardic arrest, and it's an impending rhythm where it goes into VT or VF, or it can go into asystole also. Okay, this is an hyperkalemia ECG change what you're seeing in this patient. Regular medicines include ramipril. He has presented with diarrhea and vomiting. We have learned GI symptoms are one of the symptoms of hyperkalemia. Along with it, ECG changes are there. So the first treatment what you'll be giving is calcium chloride in this patient. Elderly female who has recently undergone thyroidectomy comes with a circumoral numbness, and tingling, and muscle cramps. Investigation of choice they have asked.
Calcium levels.
Just do the calcium levels. Most likely it is an hypocalcemia this patient is having with the typical symptoms what they are presented here. A 55 years old male came to the ED with seizures. Serum sodium levels was checked by GP 2 days ago and it was normal. Okay, and the sodium levels are this one. What do you do?
The severe
hypertonic saline. Hypertonic saline.
Hypertonic saline.
Hypertonic saline, because with sears.
If this patient presented ED with generalized weakness, so what you will do?
Refer to nephrologist.
Generalized weakness.
Normal
Ideally,
saline.
there should have been another option as admit this patient.
Normal saline.
Admit, or you can just start on the normal saline and admit this patient. Normal saline plus admission will be required. Okay, usually threshold is less than 115 is very critical hyponatremia. You need to admit all the patients if it's less than 115. Any questions before we go into urology?
Assalamu alaikum.
Wa alaikum salam.
Dr. Amin, in rhabdomyolysis patient, if he came with complication of renal failure, we will go directly for hemodialysis.
How severe is the renal failure? Whether he is in end stage renal disease, in that stage he is, then you'll go for dialysis. Usually we always try with IV fluids.
Okay.
Because rhabdomyolysis itself will cause dehydration, or there is a hypovolemic state it causes. As we studied previously, there is a sequestration of fluids inside the broken myocytes that will cause hypovolemia. That's why we always give fluids first and see whether the urine output increases. Okay, if it doesn't increase, not responding to fluids, then we think of dialysis in those cases.
You mean a small amount of fluid, 25, 200?
No, you can give it. He is in acute kidney injury. He'll be in hypovolemic state. Okay. You will catheterize this patient, closely monitor his urine output. If any point of time IVC is distended, this patient is going into fluid overload state, then we'll stop the fluids, plan for dialysis.
Okay, thank you.
Urology. Urology is again surgical part of the nephrology, what we are discussing about. First, we'll be seeing an renal calculi. Renal calculi, classically, they will present with an loin to groin pain on the affected side, on the right side or on the left side where there is a calculi. Renal, more than renal, it is an ureteric calculi what we are discussing here. Renal calculi itself will not cause pain. Okay. Ureteric calculi is the one which causes severe pain because it passes through a small lumen of the ureter and it scrapes around the epithelial lining of the ureter. That's when it causes severe pain. If it's not moving, it doesn't cause pain. Because it is scraping the epithelial layer, there might be some hematuria also. That is blood in the urine or dark colored urine, or on urine dipstick, microscopic hematuria can also be seen. Okay, that is the classical presentation of renal calculi. But In elderly, if someone presents with loin to groin pain, one of the important differential diagnoses you should have is AAA. AAA stands for abdominal aortic aneurysm. So you always need to get a bedside ultrasound scan done to look out for the abdominal aorta. So never forget to get a bedside ultrasound scan done in elderly. This should be your first differential diagnosis. If an elderly that is more than 60 years presents with loin to groin pain, this can be an AAA. So what are the so what is the composition of this calculi? Most of the time it is calcium oxalate. What is the composition? Rarely you can see it is because of calcium phosphate. It can be okay. Magnesium ammonium phosphate, if there is the composition, it most likely because of the infection of Proteus mirabilis. Urate can be seen in patients who are known case of gout. Investigations, get an urine district done. In 90% of the cases, there will be some amount of RBCs, so some amount of blood will be there in the urine. Full blood count, electrolytes are important. CT scan is the investigation of choice, except in pregnant ladies and children. Children and pregnant ladies, ultrasound becomes investigation of choice. CT scan is the investigation choice in anyone else in the adult persons. Here you don't want to radiate any pregnant lady or child. That's the reason you're getting an ultrasound scan done. CT is better one because it gives an exact size and the position of the stone. For example, a patient comes, he says, I'm completely fine now. I had this severe pain, lasted for 1 hour. By the time I came to the emergency department, it is completely gone. Still, you need to get an imaging done. That doesn't mean you shouldn't get an imaging done. The pain has gone because it is not moving. Because if it is a kidney and this is an ureter, it might have got stuck here only and it is not moving. If it's not moving, the pain will come down. Once it moves, it scrapes the epithelium. That's when the pain becomes severe. So it might have stopped moving. So there's no pain. That doesn't mean the stone has passed out. So get an imaging done. Stone might have passed out, might not have passed out. Where is the stone? You'll come to know. How do you manage these patients? Pain management is very important. We are discussed in your anesthesia chapter. The preferred drug is ibuprofen given PR. You can give in any other route if PR is contraindicated. Next, second line of drug is IV paracetamol. Third line of drug is opioid. Never give antispasmodic, which is widely followed. It is not helpful at all. There is no role of any antispasmodic. How to treat these patients? Okay. You can just wait and watch in patients if the size is less than 5 mm. Or if it is more than 5 mm, what you need to do is you need to discuss with the patient. You need to explain the possible complications, like it can cause an acute kidney injury because of an obstruction. It can cause an infection. It can cause an pyelonephritis. You need to explain all this. They're okay with the risk factors. Still they want to wait, then you can wait. Otherwise, most of the time they go ahead with the surgical management. What is medical expulsion therapy? If you're planning for a non-surgical treatment, you can add up an alpha blocker like tamsulosin, which causes dilatation of the ureters and it helps to pass the stone. So usually we start on tamsulosin if the stone is less than 1 centimeter, that is less than 10 mm. What are the dietary and lifestyle changes? These are recently in 2019 guidelines have been put up by NICE, asking to advise everyone who comes with ureter calculi from the emergency department itself. Ask them to take plenty of water, in children age dependent water. Tell them to take fresh lime juice. Research has shown that it prevents calculi formation. Avoid carbonated drinks. Okay. Salt restriction, 6 grams for adults, and depending on the age, children should be restricted for the salt intake. No dietary restriction for the calcium. We have seen previously that calcium oxalate is the most common composition, but that doesn't mean if you take more calcium, you will have more calculi. So there shouldn't be any dietary restriction for the calcium intake. You shouldn't tell them don't drink milk and all. They can continue having the milk as they used to. There's no restriction. Do we admit this patient? If you're able to manage this pain and the creatinine is within the normal, which has not caused any complications, you can just discharge them. So pain management is important. If you're not able to control the pain, or because of the pain, the patient is continuously vomiting, unable to have anything orally, or because of the obstruction, because there is an calculi here causing obstruction, it can cause acute kidney injury. If this patient is already in acute kidney injury, admit. or it has led to an infection, then admit. It might be infection because of pyelonephritis or some other cause, you need to admit it. Increased risk from renal function loss. What is increased risk? If this patient is having a precious kidney, for example, he is having a kidney of transplanted kidney, he's having a transplanted kidney, so single kidney, it's a precious kidney, you need to remove the calculi as soon as possible, because you can't give any chance for this kidney to fail because it's a very precious kidney. If the diagnosis is unclear, it may not be calculi, it might be a AAA, or if something else is going wrong, you're not sure, or the CT scan doesn't show a calculi, but this patient is still having pain, so you don't have a diagnosis, admit those patients. Acute urinary retention. Acute urinary retention, basically, it's a very common presentation to the emergency department. Unable to pass urine, presented by elderly. Most common cause is infection of acute urinary retention. Infection can lead to acute urinary retention, or next most common cause is benign prostatic hyperplasia. There are various other causes. There's plenty of causes as described here. There might be some anatomical abnormality or in foreign body, or there might be a hematoma or in cancer. A functional cause might be there because of spinal injury, or because of chronic neurological disorders like Parkinson's, or a spinal cord injury, or an alcohol toxicity can cause acute urinary retention. Female specific, mainly prolapse or in pelvic mass, can cause acute urinary retention. But you need to remember, infection is the most common cause, followed by benign prostatic hyperplasia as the second most common cause. So what are the investigations? As we said, infection is most common, so you'll get a full blood count. You need to look out for the renal function also, because there is an acute retention of the urine. That means outflow of the urine is obstructed, whether it is causing an acute kidney injury or not. That's the reason you need to get a renal function test done. If there is an acute kidney injury already happening, ultrasound scan might be required. Never get a prostate specific antigen done in the ED department. There is no role of prostate specific antigen. In fact, if you get it done, it might come false positive rates if you get it done in an acute retention patient. So never ever get this done. It will give a wrong diagnosis. So you don't send it. It's not an investigation to be done from the emergency department. You need to remember that. What is the treatment here? What we do is we catheterize every patient. Okay. We do, after catheterization, we drain the urine. Okay, we note down how much urine they have passed, how much was acute retention, we note down the urine. Once we catheterize, we ask them to follow up after 2 weeks in the TWAC clinic. What does TWAC stands for? Trial without catheter. Okay, it's a clinic run by urologists where they will remove the catheter and see whether they can pass the urine or not. Why do we refer them after 2 weeks? Once you drain the urine, can't you just remove the catheter and send them home? The problem is, studies and the research have shown that in 70% of the male patients, within a week time, they will come back to the emergency department again with acute retention of urine. That's the reason we don't remove the catheter for minimum of 2 weeks. After 2 weeks, we refer them for the trial without catheter, that is TWAC clinic. If you see the NICE guidelines, they say suprapubic catheter is the preferred one, then doing a normal Foley's catheter through the PNS normal Foley's catheter. Why and suprapubic catheter is a preferred one? Because it causes less infection. But practically it is not possible. Still widely in UK, urethral catheterization itself is followed. I told you we need to monitor the urine. We can't immediately discharge after placing an Foley's catheter. Why? Post-obstruction diuresis can happen. Sometimes there might be loss of urine around the range of 8 to 20 liters per day. So this patient will go in severe dehydration, because most of the time it is an elderly patient who comes with urinary obstruction. In these cases, you need to admit this patient. So that is an indication for admission. If this is caused dehydration, also is an indication for admission. Acute retention itself can cause infection, so sepsis is also an indication for admission. Any AKI is indication for admission. If the patient is unable to manage at home because of any reason, so social reason or social admission also you can do it. That is dementia, one of the examples what we're giving. Sometimes this patient might be having acute urinary tract sepsis or constipation, should be treated before attempting trial without catheter. Okay, for example, after you're suspecting an UTI as the cause, so you collected urine routine and urine culture, you started on antibiotics. He goes to the talk clinic. Still the patient says that I'm having a low-grade fever. I feel I'm still passing a lot of urine. That means there is increased frequency. Also, this patient is having fever. That means infection is not resolved. So we'll continue antibiotics for a longer duration of time, and higher antibiotics might be required according to the cultures. Then we'll ask them to come back to the clinic again to remove the catheter. That is trial without catheter. Any questions till here? You can ask me now. Yes, please.
Sorry, I have 3 questions actually. You mentioned that antispasmodics should not be given. What is the reason for this, sir?
It doesn't work. It doesn't cause
It doesn't
relaxation of the ureters as it's widely thought so.
All right. And sir, what about the role of IV fluids? Would it help in these cases for renal colic?
It will cause more pain if you give it in an acute state. Why does a patient with an obstruction will have pain? 2 things which causes pain in an ureteric calculi. Okay, this is a diagram is an ureter. Ureter stone moving around, one thing. Another thing is there is a capsule around the kidney. Okay, as this kidney keeps on, if you give more fluid, this kidney will make more urine. More urine means this kidney is not able to secrete it out, so it will go into hydronephrosis. Kidney will enlarge. If it enlarges, the capsule will get enlarged. He'll have severe pain.
I see. Sir, any choice of analgesia is preferred over normal analgesia, or we just start with ibuprofen and go upwards?
No, ibuprofen is as good as an morphine.
And this is, sorry, sir, is means per rectal, or we can give it as oral, or how does it work?
Rectal is the preferred. Ibuprofen is better than opioid.
Right.
Better than paracetamol, better than opioid, better than any other drugs. That's why that's the first one. Okay, this patient will present pain 10 out of 10 severe pain they present with. Ibuprofen is the preferred one.
Thank you so much, sir. Thank you.
Anyone has any other questions? You can ask me now.
Yes, hi, Doctor. Hi, Doctor.
Yes, please.
Yes, you said something about the alpha blockers in the renal stone, I think. Does it work for elderly here? As you said that you consider alpha blocker.
It does work.
Is it preferred to be used here in UK?
Yes, that's given in NICE guideline 2019. They have advised medical expulsion therapy can be given in anyone who has an calculi of less than 1 centimeter size. It is according to the NICE guideline, UK guidelines itself.
Okay, thank you very much. Thank you, sir.
Dr. Amin, regarding renal stone, need a renal function test?
Yes, every patient who comes with an renal calculi needs an renal function test. Why? One of the admission criteria here is acute kidney injury. Without the creatinine level, you will not be able to diagnose whether this patient is in acute kidney injury or not. It will be difficult for you to diagnose because you're not monitoring urine for a 6 hours duration in the ED.
But Doctor, I mean, sometimes in one side compensate to other side. This kidney is injured, but the other kidney is functioning. There is misleading about the renal function. That's right?
It might be misleading, but still we are seeing acutely is their creatinine increased or not. If it's only, see, why the function will reduce because there is an obstruction. So this obstruction, if you feel it is less than 5 mm, it can be removed by itself by medical expulsion therapy. Then you can just discharge him. Once the calculi goes off, the kidney functions will retain. But if the kidney function is 1.5 times, that is in 1.5 times it is increased, means more than 50% of the nephrons are not working. That's when you need to be worried about and admit this patient. It will require to be removed surgically, this calculi.
Sir, for pediatric patients, the same for adult about renal stone?
Yeah, it's same as adult and pediatrics.
Dr. Amin, in acute urinary retention, You said some patient will develop after catheterization post-obstructive diuresis. How can suspect this patient will develop, or there is something to determine this patient may develop this?
Difficult to assume that this patient will have, or difficult to predict it. That's why we don't immediately discharge them. We keep them for observation for a couple of hours before we discharge them. Okay, as soon as you catheter, usually what's there in the bladder, if, for example, if there is 1.5 liters of urine, that will drain off. But if it's continuously coming and you need to change the bags, usually the bag will be of 2 liters, a large bag, large Euro bag will be of 2 liters. If you have to change multiple times, that means this patient is having post-obstruction diuresis. You need to admit this patient.
When I refer patient for urologist,
We refer everyone to the urologist. Just 1 second, hold on. We refer every patient to urologist through TWAC clinic, that is trial without catheter clinic. There it is run by urologists. So everyone goes to the urologist after 2 weeks point of time. If you're discharging these patients, if you're admitting this patient, again, they go under the particular specialty and they will take care. So these are the indications for admission.
okay, thank you.
Yes, please.
I missed the explanation why we don't give antispasmodic.
It is not effective. It doesn't cause any dilatation of the ureter.
Okay, thank you.
Lower urinary tract infection. We call it lower if it's in the bladder, or if it's in the ureter. Mainly we are calling about bladder. Bladder or in urethra, what we are calling about. Bladder is nothing but cystitis, we call it. Okay. So it differs from non-pregnant lady to a pregnant lady. In non-pregnant lady, we are talking about, okay, we can just give them and backup antibiotics, or you can immediately start the antibiotics. If you're immediately starting, collect for the urine culture. In non-pregnant ladies, particularly in women's, why urinary infection is common? Because of their anatomy. Okay, because of the ureter itself is very short compared to the male counterparts. That's why they are more predisposed to urinary tract infection. Usually what we do is we give backup antibiotics. That means we prescribe them antibiotics, tell them don't use it till 48 hours. If you're improving, not required at all. If you're not improving or worsening, start taking the antibiotics. What about in anyone who presents with urinary symptoms and you're suspecting lower urinary tract infection, who are pregnant lady or in men? In every pregnant lady and in every male person, you need to start antibiotics immediately. Before starting antibiotics, collect urine culture. When to change the antibiotics? In pregnant lady, you get the culture reports and the culture shows the antibiotic what you started is resistant, then you'll change it. In men and non-pregnant to men, along with the bacterial resistance, the culture report should show and the symptoms should not be improving. If both of these are present, then you will be changing the antibiotics. If the symptoms are improving, then you'll not change the antibiotic. Okay, it doesn't require to change the antibiotic according to the culture reports. How does this patient presents? Any urinary tract infection, usually they'll have some burning sensation. Increased frequency of maturation will be there. Sometimes they'll have suprapubic pain. These are the 3 classical symptoms they present to the emergency department. What we suggest them? Self-care. For pain, if there is pain, take on the counter paracetamol or ibuprofen. Drink plenty of fluids. It helps to wash out the bacteria what is there. There is no role of urine alkalinization. For example, there was previous thought that go drink a lot of cranberry juice. Okay, and in some parts of the countries, even where I practice, there also we tend to give syrups which alkalize the urine. It has no role at all. NICE doesn't recommend you to prescribe any alkalizing agents or advise them to take cranberry juice. Asymptomatic bacteriuria. This is not very important from emergency point of view. Every pregnant lady gets screened by testing their urine. If the urine shows significant amount of bacteria, we go ahead and treat them. Even though if they are asymptomatic, we go ahead and treat them. So it is known as asymptomatic bacteriuria. Okay, we don't screen anyone who is asymptomatic in any other age group. Anyone who is not pregnant or any male counterpart, we don't test it if they're not asymptomatic. They should be symptomatic to test urine. Antibiotics preferred when is nitrofurantoin in both pregnant and non-pregnant. Okay, kidney function should be good to give antifurantoin. That much if you remember, it's enough. It's not required to remember second choice and all. Basically, this will be given according to the hospital guidelines. You can prescribe according to the hospital guidelines. You did not remember. Acute pyelonephritis is also known as upper urinary tract infection. Okay, UTI, upper urinary tract infection. This is not a lower upper, because up if you go, there is a kidney. This is an infection of the kidney, is acute pyelonephritis. Most common organism is E. coli. For the diagnosis purpose, you need to prove that this patient has an urinary infection by at least doing an urine routine or urine dipstick. He has an urinary infection. Then along with this, he has an loin pain. That's when you make a diagnosis of acute pyelonephritis. Okay, you can't just get a scan done and say that there are perinephric strands, fat strandings around the kidney, most likely, and pyelonephritis on imaging. That's not a right way to diagnose. If there is an UTI, that is, there is an urine infection, plus there is a loin pain and or fever, high-grade fever we are talking about, then you are assuming that it is an pyelonephritis. Most common organism which causes pyelonephritis is E. coli. What is the indication for admission? So there are indication for admission. That means not every patient requires an admission who have an pyelonephritis, who is an young individual with minimal or well-controlled comorbidities, like well-controlled hypertension he has, okay, and good social support he has at home, and he is not in sepsis. That means the infection is not severe. You can discharge this patient. Rest, every patient needs to be admitted, including the patient who are not responding to the oral antibiotics for 24 hours needs to be admitted. Along with it, a pregnant lady needs to be admitted. If there is a pre-existing renal impairment, admit. Evidence of renal stone, that is obstructive cause for pyelonephritis, is an emergency. You need to admit. Anyone who is immunocompromised, diabetic, or is catheterized, you need to admit all these patients. So the easier way to remember, a healthy individual can be discharged. If something is wrong, is elderly, pregnant, or there is a kidney injury or a stone which is causing immunocompromise. So anything other than this, what I have mentioned is there, you go ahead and admit those patients. Young, non-pregnant lady. Antibiotics, again, if you're in sepsis, you might have to do fluid resuscitation, give antibiotics, and follow sepsis 6. You need not remember the exact antibiotics which needs to be given. If the patient is having severe pain, always give analgesia. Pain management is important part of emergency department. Hematuria we are talking about now. Hematuria is presence of blood in the urine. Okay, it can be microscopic, which you can't see it only on testing. You know there are few RBCs present, or it can be macroscopic. There is gross hematuria also, we call it. So you can obviously see in the urine sample itself, it is red in color, so you know it is bleeding. This patient is bleeding acutely. So what are the causes for hematuria? There are extensive causes for hematuria. A cancer can cause, or in pre-renal cause like in sickle cell disease can cause, inflammation or renal cause like inflammation, or in calculi can cause. Calculi in ureter can cause, obviously we have discussed previously. A malignancy of a bladder can cause. Okay, schistosomiasis can cause. Urethral malignancy also can cause. Sometimes it might be false hematuria because of colored urines. For example, rhabdomyolysis causing myoglobin can cause hematuria. So there are various causes. You need not mug up everything. Okay, we just put up these causes so that we can stress. If you can remember any infection, any kind of cancer, or any trauma, so any foreign body can cause hematuria, then you can reason it out. Investigations is directed towards cause as well as how much blood he has lost. So you need to see kidney functions. Is it affected because of the hematuria or not? Urine dipstick is important to see for infection. Full blood count, clotting profile, cross blood matching, and renal tract imaging. If required, you are getting it done. If, for example, you're thinking it might be an ureteric calculi, then you're getting a CT KUB done. Cross match blood Sometimes they might have cross hematuria and might have lost lots of amounts of blood. You might have to do and blood transfusion in these patients. That's why cross matching, clotting profile and all becomes important. When to admit this patient? If they have lost lot of blood, then you need to admit this. That means they have symptomatic anemia. There is significant anemia which is causing it. Then you need to admit this patient. As blood is gross hematuria, their blood is getting accumulated, clots retention can happen. This clot retention can cause acute urinary obstructions. Admit this patient. Clots itself, when they are trying to push it out through the urethra, they might have severe pain, uncontrolled pain. Admit. Evidence of severe infection, basically sepsis, or evidence of any kidney injury. Admit these patients. So all this admit. So what we'll be doing basically here, we're trying to see the cause and treat the cause here. What if there is clot retention, and what you need to do? You can do bladder wash. Bladder wash is required from the emergency itself. How do you do an bladder wash? Bladder wash is done by using three-way catheter. Okay, there will be 3 lumens. Through one lumen will be pushing the fluid, and from another lumen the fluid is coming out, which is going through the bladder and coming out. Another lumen is to inflate the bulb. Okay, 3 lumen catheter will insert, a large 3 lumen catheter will be inserted, and you will be doing bladder wash. You start in the emergency department, admit under the urologist, they will take over from here. What is acute prostatitis? Inflammation of the prostate gland is known as acute prostatitis, and most of the time it is because of infection. What to do in this kind of patients? What we can do here? So what we do here is we start them on antibiotics. You need not remember again this antibiotics, but you have to remember this antibiotics is given for very long duration. 2 weeks they give, they review and see. If required, they will extend for a few more weeks. So minimum of 2 weeks, you need to start them on antibiotics. How do they present? They present similar to that of an urinary tract infection, like an urine infection. Along with that, there will be perianal, that is around the anal region, there will be pain. And if you do an PR examination and palpate the prostate, it will be tender, but though it is not recommended. If you palpate or if you massage the prostate, that might lead to spread of infection to the rest of the body and resulting in sepsis, so it is not recommended. Anyone who complains of perianal pain and perianal pain along with urinary symptoms, think of acute prostatitis, start them on antibiotics for a longer duration. Always collect urine culture before you start on the antibiotics. If they are systemically unwell, admit them. IV antibiotics are required. What do I mean by systemically unwell? That means if they are in sepsis. Okay, sepsis usually we see either Q-SOFA or Sears criteria. We'll be learning in our infection chapter how to find out the patient is in sepsis or not. If they are systemically well, then oral antibiotics should be fine. You are prescribing them for a very long duration. When to suspect in prostate abscess? You suspect in prostate abscess who has in prostatitis, so all these features are present. Along with it, there is sign of toxicity. That means this patient is in sepsis. If the patient with prostatitis is sepsis, you need to always think about there might be an abscess which is causing an sepsis. Or there is difficulty in passing urine and symptoms are lasting more than 5 days. Think about prostate abscess in these cases. Okay, this is important how to differentiate between prostatitis. Worsening of prostatitis, if this is a prostate, there might be accumulation of the pus there causing an abscess. If there is an abscess, usually this patient will be very toxic and he'll be having difficulty in passing urine. Along with that, the symptoms will be lasting for more than 5 days. If all are present, then think of prostate abscess. Otherwise, it's just prostatitis one you need to think of. Any questions still here? You can ask me before we go into testicular torsion.
Doctor, I mean, how to differentiate between prostate abscess or prostatitis?
This is the slide, what it says. Okay, signs of toxicity. You're looking at
without association.
Prostate abscess, when you suspect a prostate as associated with a prostate abscess, prostatitis associated with prostate abscess is signs of toxicity should be there, and he should have difficulty in passing urine, and symptoms should last for longer than 5 days. Okay.
This
In
prostate abscess can be seen by ultrasound also. We can do.
You can make out on an ultrasound scan. You can pick it up on an ultrasound scan, but it's difficult, but you can pick it up. Okay, usually an dodgy mass will be there in the prostate. They assume that it might be a prostate abscess, and usually ultrasound guided prostate abscess drainage will be required if there is an abscess. Again, it's a further management for the urologist, not an emergency department management. Treatment wise, treated similar to that of the prostatitis. You'll start them on IV antibiotics and admit them.
Is there a rule for PR?
PR examination you're asking?
Yeah.
We usually don't recommend to do an PR examination because massage of the prostate can spread the infection to rest of the parts of the body. That's why we don't recommend doing an PR examination.
Okay, thank you.
Testicular torsion. So testis can rotate on the spermatic cord, can cause acute compromise in the arterial blood supply. That's when the testis undergoes gangrenous changes. 6 hours it takes to go under complete gangrenous changes. So you need to intervene within the 6 hours from the onset of symptoms. Otherwise, the patient will lose his testis. Why does this happen? Most of the time it happens because of something known as bell clapper syndrome. What is that? This thing what I'm drawing here is tunica vaginalis. Okay, high attachment, that is, it is completely circling the testis along with epidermis. That is known as high attachment of tunica vaginalis. Whenever there is a high attachment, testis tends to rotate on itself on the spermatic cord. This is where it is rotating on itself, causing acute vascular compromise. The pain will be acute in onset, associated with abdominal pain or vomiting. Testis will be tender, and most of the time it will be horizontally lying. Okay, and it will be associated with loss of cremasteric reflex. That is, if this is the thigh, when you strike inner part of the thigh with your pen or any object, there will be updrawing of the testis. If that is absent, then loss of cremasteric reflex. Then it is highly suspicious of testicular torsion. You refer every suspected testicular torsion to the urologist. When to get an Doppler scan done? Doppler scan doesn't help you when you're suspecting a testicular torsion. When your equivocal diagnosis is there, then you can think of Doppler scan. What do I mean by equivocal diagnosis? You say this more looks like an epidermoarchitis, might very less chances it might be testicular torsion. Then just to rule out, then you can get a Doppler scan done. But if your first differential diagnosis is testicular torsion, Doppler scan, you shouldn't get it done because it doesn't rule out testicular torsion. Only thing which can rule out is opening your scrotum and seeing whether it is gangrenous or not, whether there's vascular compromise or not. None of the investigation will help you with the diagnosis per se. What is that? So ED management is pain management and reference to the urology team. Differential diagnosis, one of the important differential diagnosis is epididymis, or along with the testicular inflammation, that is orchitis, epidermoarchitis we call it. Another one important differential diagnosis is torsion of the hydatidity of Morgani. What is it? It is nothing but an embryonic remnant which is, it is undergoing necrosis. Okay, it presents as a blue dot. We call it as a blue dot sign. Okay, whenever there is a blue dot, it is labeled that it is torsion of hydatidity from Morgani. Okay, it is a pathognomic feature. No investigation is required. You will just give painkillers and discharge them home. So in question, this similar image has been given in MRChem exams. Sometimes they can just describe as blue dot. If blue dot is there, you have ruled out or doesn't require any scan to be done, doesn't require urologist to be informed, you are just discharging home because this torsion of hydatidity of Morgani which requires only pain management. Some NSIDs you give and you discharge them home. What is epidermoorchitis? Epidermis, this is the epidermis. Inflammation of this will cause epidermitis. Along with this, sometimes even testes can get inflamed. That is known as orchitis. Okay. How do they present? They present with a chronic pain. Usually it will not be acute. They present with a chronic pain, testicular ache. And again, epidermis, when you palpate this, it will be very tender. It will be horizontally lying testis compared to that of the testicular torsion, where it is it is vertically lying in epidermoorchitis, horizontally lying in testicular torsion. Climatic reflex will be intact here. Fern sign will be positive. What is fern sign? When you lift up the testis, the pain will drastically come down. That is known as fern sign. That will be positive. If the pain comes down, that means it is positive. That means most likely it is epidermoorchitis. Okay, there might be some associated urethral discharge and fever because this is an infection. What we do here, we take urine culture and urine routine sample, urine sample for urine culture and routine. Then you take urethral swab, especially checking for sexually transmitted diseases. Then you refer to the gum clinic. You don't start any antibiotics, just refer to the gum clinic. For any particular reason, if you're not able to refer to the gum clinic when you're suspecting and sexually transmitted disease, then you need to start the antibiotics in the ED itself. This antibiotics you need to remember. The ceftriaxone and doxycycline in sexually transmitted organism you are suspecting. If it can be a sexually transmitted or enteric organism, then you'll be starting ceftriaxone and ofloxacillin. Only enteric organism you're suspecting, then ofloxacillin you're starting. Dosing is not important. The drugs at least you need to remember. If you're thinking it is a sexually transmitted disease, then you need to refer them to the gum clinic, or you yourself should take the onus of involving all the sexual partners and screening them for sexually transmitted diseases. That's why we tell when you're suspecting and sexually transmitted disease, always refer to the gum clinic. Gum clinic will do all the necessary investigations, including training of the sexual partners and screening them for sexually transmitted diseases. Everything will be done by gum clinic itself. So always refer them to the gum clinic. I keep telling here sexually transmitted disease or enteric organism meant to suspect. Any young individual who is sexually active, you're thinking of an sexually transmitted organism only. If an middle-aged or more an older age person who is sexually active, then you can think it might be an enteric organism or it might be an STD organism, that is sexually transmitted disease. An elderly patient who is not sexually active, you should always think of an enteric organism. Okay. A young individual also who is not sexually active for a few months, then always think of enteric organism. That's how you need to suspect them. That's how you need to treat them. Antibiotics here, you need to remember. This is one of the special circumstances where they can test you on antibiotics, where you have to remember. Priapism, one question will definitely appear in your exam. It's a very important topic. There are two kinds of priapism. One is low flow, one is high flow. What is the difference between low and high flow? Low flow, there is a venous occlusion. High flow, there is a trauma to the artery. So the artery is leaking or bleeding here. So cause for high flow is only traumatic or direct cause. For low flow, that is venous occlusion, there is plenty of causes like spinal cord injury, sickle cell anemia, or medications can cause like fluoxetine, recreational drugs like cocaine can cause. So there are various causes for low flow, also known as ischemic flow. This is a high flow or non-ischemic flow. Okay. Drugs which are causing priapism, the important ones you need to remember is fluoxetine, prazosin, and terazosin. Lithium can cause risperidone and olanzapine, warfarin and heparin. These are the drugs you need to remember from exam point of view that can cause priapism. If you're able to remember everything, it's very good. How to treat? Most of the questions comes on how's the treatment of priapism. First, what we do is, if there is a priapism, what is priapism? Priapism is nothing but rectal, nothing but erection of the penis. which is not sexually stimulated, or it is sexually stimulated lasting for longer than the expected duration. There is no precise definition for the expected duration. Someone comes with that one, what you do is you take a sample. You take a blood sample. Why you are taking a blood sample? To differentiate whether it is in low flow, which will be venous. It will be more often VBG if you take a blood sample here and you're doing a blood gas. If it's a high flow, it will be arterial blood gas. So it will be an ABG where PO2 and PCO2 will be in the normal range. Here there will be not in the normal range because it's a venous blood what you are getting. How to treat it? What we'll do first thing here is we infiltrate the local anesthesia and we aspirate using a butterfly needle. Where do we aspirate from? Corposa cavernosa. So from here and here we aspirate. Corposa cavernosa is the place we aspirate from. Till when we aspirate? We continue to aspirate till bright red color blood comes in. If that fails, we can irrigate the patient with normal saline. If that fails, then we are infiltrating phenylephrine. If that fails, requires distal shunting. If that fails, then it might require redoing or proximal shunting. Usually they'll ask still here only because all this is managed by urologists, so out of scope of emergency department. So first step is give local anesthesia. Second step is aspirate after giving local anesthesia using a butterfly needle from corpora cavernosa. Next, you can irrigate. Once you are irrigated, still priapism persists, then you give phenylephrine in intracavernosal space. That is, here you are infiltrating phenylephrine. If that fails, involve the urologist. You can't do much. Okay, questions appear on low flow. Till now, they are not asked on high flow because you can't do much for the high flow. It's an arterial bleed, so it is bleeding. You just wait and observe so that clot forms. If a clot is not forming, you need to involve the interventional radiologist so they can do an arteriography and embolize the culprit artery. If that doesn't work or it fails, then surgical ligation needs to be done where urologist needs to be involved. So nothing much can be done. Simultaneously, you need to treat the underlying disease also. For example, there is a sickle cell disease which is causing it. Priapism is an indication for exchange transfusion. So you need to involve if it is a pediatric, you involve the pediatrician, arrange for the exchange transfusion because it takes time for an exchange transfusion. In the meanwhile, you can treat for the priapism as given here. Fournier's gangrene. As the name suggests, it's an infection of the scrotum, basically. That's the perineal region and genital region. Infection is usually seen in immunocompromised individuals. It might be because of diabetes or chemotherapy or obese patients or trauma which has caused it. So some trigger should be there and some immunocompromisation should be there. It is caused by group A beta hemolytic streptococci, also known as streptococcal pyogeny. Is the most common organism they can ask you question on here. They present within classical triad. There will be swelling in the groin region. Along with it, there will be severe pain and high-grade fever. If this triad is there, this is an emergency, that is Fournier's gangrene. What investigations you can get it done? You need to get all your routine investigations in the sepsis guidelines. Okay, or like full blood count, blood culture, urine culture, CRP, then get a venous blood gas to see the lactate levels, all those. Along with it, imaging is also important. If you get an X-ray done, you can see gas in the groin region. This is a scrotum. You can see black colored dots. That is nothing but gas. Similarly, in a CT scan, you can see black color here. This is nothing but gas. It is very much suggestive of an subcutaneous air is present. This is nothing but is a pathognomic feature of Fournier's gangrene. It's one of the important clinical features of Fournier's gangrene. So getting an X-ray or a CT scan is helpful. Most of the time, we end up getting a CT scan than an X-ray. In exam, they have given this CT scan and this triad and asked you for diagnosis. So you need to remember it's a subcutaneous air. Sometimes they might ask what is the CT scan finding here. This is a subcutaneous air. This black color what you're seeing is the subcutaneous air. Here also is the subcutaneous air what you're seeing. Air is seen as black in the imaging. From emergency, what you'll do is start him on high flow oxygen, broad spectrum antibiotics because it's an infection caused by streptococcal pyogeny. Fluid resuscitation if he's in shock. then involve the surgeons on an emergency basis so that they can take up for debridement. Debridement is a must in these cases. They should take up directly from emergency department to the operation theater. In the meanwhile, just start them on broad spectrum antibiotics, fluid resuscitation, and high flow oxygen. Any questions you can ask me now before we go into question and answer session?
Sir, what is gum clinic?
Okay, GUM clinic stands for Genitourinary Clinic. Okay, it is short form. I think I forgot to tell you the long form. GUM clinic stands for Genitourinary Clinic. So it is a single station where there will be a GP and an acute medicine doctor where they'll screen them, involve all the sexual partners, screen them for sexually transmitted diseases, get all the relevant investigations, start them on antibiotics if required.
And so how to confirm it as low flow or high flow?
See, with the history, you'll come to know a little bit, but the most of the time, if you don't get an history or something, you'll get a blood gas done. So you'll aspirate from the corpora cavernosa, 2 ml of blood, and that aspirated blood run and blood gas analysis. Then see whether it's an VBG or ABG. If it's an ABG, that means it's an high flow, it's an arterial injury which has caused the bleeding here. If it's a venous blood gas, then PO2 and PCO2 will be on the higher side, PO2 will be on the lower side because it's a venous blood. So you know it is a venous blood, you can treat it. But most of the time, practical purpose, we don't do it because we know only trauma causes high flow priapism. If there is no history of trauma, then it is a low flow, and we go ahead with this algorithm.
Thank you, sir.
Sir, is the time is
Dr.
important in case of priapism? Like if patient came after 3 days?
After 3 days, it's unlikely a presentation to the emergency department. Okay, again, the treatment remains the same if he comes after 10 days also. Highly unlikely anyone presents after 3 days. It's a very painful condition. No one will come. It will be in hours, the presentation.
Okay, I mean, what about the penile fracture?
We'll discuss in a question about penile fractures. Penile fractures is basically if there is a trauma because of a sexual activity or by direct impact of the trauma. So it's just deformed penile fracture. So you'll refer to the urologist. So nothing much you can do in the emergency department.
Sir, what is the high flow oxygen? What is the role of high flow oxygen in Farner's gangrene?
In Farner's gangrene, high flow oxygen, basically we are talking about treating like in sepsis. This patient will be very sick patient. That's why broad spectrum antibiotics, fluid resuscitation, high flow oxygen. Mainly we're talking about sepsis 6 here. Okay, these patients will be very sick patients if they have Farner's gangrene and it spreads very rapidly. There will be acute presentation. So we need to act fast. So basically, what they're telling here is treat it as in sepsis. This patient treat it as in sepsis. Involve the surgeons on an emergency basis.
Sir, any role in emphysema type Farner's gangrene of oxygen?
I didn't get your question.
Any role of emphysematous type of Farner's gangrene by the supplement of oxygen, high flow oxygen?
It might be helpful, but again, studies needs to be done. They say more, just treat it like an sepsis. Okay, there are few studies saying that it might be helpful giving high flow oxygen in these patients, but again, it's not any recommendations or not there. Clinical guidelines have not come up on that. We'll go ahead with question and answers for the urology chapter now. So we have an young patient who has presented priapism to the emergency department. He has a history of recurrent priapisms, which usually resolve spontaneously, but this attack is taking a long time. Lidocaine has been given, but no response was seen. What is the next step in the management?
Aspiration with a needle.
We need to aspirate the blood from. You need to aspirate the blood from corporosa cavernosa. You need to remember 2 C's, corporosa cavernosa, 2 C's. Remember that, they might ask question on that. We have a 12-year-old boy came to the ED with severe testicular pain, had a similar attack before, which resolved spontaneously. Doppler scan was been done as diagnosed with testicular torsion. What is the most probable diagnosis of the most probable cause of his testicular torsion? They're asking.
Bell clapper.
Yes, bell cappers. This is the same thing what I have explained you previously. This is tunica vaginalis, which is high attachment. What you're seeing here. So you have a 17 years old boy who come to the emergency department, testicular pain. On examination, you see a blue dot sign, which is positive, and the image of the same is been given. What's the probable diagnosis? This is a pathognomic feature of torsion of iridiform Morgani. Repeatedly, every day they're asking this question. They might just give blue dot in the stem of the question, or they might just give an image. So always choose torsion of iridiform of Morgani.
Doctor, this one best non-steroidal treatment, no surgical intervention, nothing?
Sorry? For the treatment?
This patient, the treatment just non-steroidal, will not give anything another?
Pain management is the treatment. Okay, no other treatment is required, just pain management and discharge home. Okay, no other treatment.
And so do we need
need for referral?
Do we need to refer for urology?
No. Okay. Just pain management and discharge.
Dr. Amin also called the testicular appendix as another name for her.
Yes, you're right. It also called as testicular appendix. Which of the following is not seen in epidermolysis?
No pain relief and elevating testis.
You see that actually.
Fern sign,
Fern
what
sign
they're talking
positive.
about here. So you don't not seen, they're asking. Presence of cremasteric reflex, fever might be there. Yes, urethral discharge might be there. Diffuse swelling of the testis, yes. This is the right answer here. This is nothing but Fern sign. Fern sign is positive here. There will be relief of pain on elevating the testis.
Hello.
We have a 50 years old man who was type 2 diabetes, came to the ED with groin pain. CT scan is shown below. What's the probable diagnosis they are asking?
Fornix gangrene.
Yes, that's right. This is a Fornix gangrene, what you're seeing here. Again, same thing. What is the most probable organism which is causing this? They have asked.
Group A streptococci.
Yes, group A streptococci is the right answer here. Which of the following is not seen in epidermolysis? Again, it's the same question.
B. Pain relief.
Sorry.
In elevating.
Which one of the following is not seen there? The right answer here is absence of cremasteric reflex. Torsion of testis. Okay, pain relief on elevation of testis is seen in epidermolysis. Fever is seen. Urethral discharge is seen. Absence of cremasteric reflex is not seen in epidermolysis.
Yes, yes.
Okay, now we have a patient who is unable to pass urine. Okay, he had a snapshot while having a sexual intercourse. Okay, immediately there was loss of erection. There is a bruising and swelling over the penis. Since then, he is unable to pass urine. Bladder is distended on examination. What is the next immediate step in the management? First, I want, what is the diagnosis here?
Urinary
fracture penis is the diagnosis along with acute retention of urine. So what you will be doing first here?
Suprapubic catheter.
Suprapubic catheter is the first step here. So how to make it? Whenever you have a penis fracture, next thing you need to see is whether the bladder is full or not. That is, whether there is an urinary retention or not. There is no full bladder or there is no urinary retention, you can directly refer to the urologist. If there is a full bladder, then you need to do SPC before you refer to the urologist, because this patient will be in severe pain. Chances of bladder rupture are there in acute urinary retention. That's why get a suprapubic catheter done first. Don't do a normal, don't attempt a Foley's catheter in a fractured penis.
Dr. Amin, what about the retrograde urethrogram?
No. This is a fractured penis. You're just getting urologist's opinion done. Don't get an retrograde urethrogram also. Okay. Okay. So we'll go for the next question here. The elderly male treated for a urinary tract infection twice in last month with antibiotics by his GP. Now he is complaining of pain on defecation. Most likely diagnosis.
Prostatitis.
Pain on defecation is also nothing but tenderness or pain around the perianal region. The diagnosis for prostatitis. Okay, in abscess, this patient will be very sick, and usually the symptoms will lasting more than 5 days. Along with it, there will be some urinary symptoms. There are no urinary symptoms here. Though the urinary symptoms are there, they're not telling it is lasting for more than 5 days, and this patient is not toxic appearing, or this patient basically is not in sepsis. So choose prostatitis here. We have a 78 years old gentleman who presents with a testicular pain on examination. Patient is febrile, tenderness in the epididymis, likely causative organism.
E. coli.
Elderly patient, entering organism, E. coli, you need to think about. If the same patient was around 30 years old, then you need to think about sexually transmitted like gonorrhea and chlamydia. You have a 10 years old boy who is a known case of sickle cell disease, complaints of penile erection since last 6 hours. Vitals are stable. Next best step.
Aspiration.
First, oxygen.
Aspiration is the right treatment here.
But the
Why
patient
oxygen?
still high flow.
Can anyone please tell me why you are thinking about oxygen?
Is this patient sickle cell disease so high flow? Management as high flow.
For sickle cell disease, latest recommendation is just to maintain oxygen levels more than 94%. Not to give oxygen for everyone. Okay. So this patient's vitals are stable, so he's not hypoxic to give the oxygen. So don't give oxygen thinking about. Exchange transfusion, yes, it is an indication for exchange transfusion, but exchange transfusion takes time. Okay, because what actually is done in exchange transfusion, you draw complete blood from the patient. At the same time, you are infusing blood in another vein. Okay, so you need 2 IV cannulas. In one, you are aspirating the blood, and another one, you are infusing it. So usually machines are available to do an exchange transfusion. It takes time. You need to involve the pediatricians. You need to calculate the intravascular volume before you start the exchange transfusion. So the first ideal step here is just to aspirate. Ideally, it should have been lidocaine. First, you give lidocaine, then you go ahead and aspirate. Otherwise, it will be painful procedure. As they have not given lidocaine, the next best step is aspirate. We'll talk about more about sickle cell disease in coming up chapters. I think in hematology, we'll study about sickle cell disease. So don't worry about the management. Okay.
Excuse me, doctor. But
yes,
you mentioned before the patient has non-ischemic priapism. It's just for observation and like that, not managed as aspiration or like patient of ischemic priapism.
Yes, that's true.
Yes, according to that, the patient with sickle cell disease is go under of high flow, non-ischemic.
No, it is not non-ischemic. It's a venous occlusion. What you are seeing here, it's an ischemic because of venous occlusion. What you are seeing, high flow. What do we call it as a high flow? High flow is nothing but arterial injury is there. When does an arterial injury happens? There should be a direct trauma. There is no trauma history here, so you're not thinking about high flow. You're thinking about low flow here. One of the causes for low flow is sickle cell disease. If you go back, if you see in the causes there, we have also mentioned sickle disease, hematological disorders like sickle cell disease can cause venous occlusion that results in priapism.
Okay, thank you.
Which sign or symptom is seen in testicular torsion? Seen, they are asking.
Loss of cremasteric
is seen in testicular torsion.
Dr. what is the Bergen sign?
Sorry?
In previous question. Bergen sign or what? What is
Fern
it?
sign. On elevation of testis, the pain comes down. That is known as Fern sign. That is seen in epididymitis.
Then
okay.
orchitis, yes.
Epididymitis orchitis, you see this one, Fern sign is positive in epididymitis orchitis. Where you elevate the testis, the pain comes down. We have a 70 years old gentleman who has pulled his Foley's catheter out. He has come from nursing home. On examination, there is bleeding from the urethral site, you notice it. What will be the next best step here?
Suprapubic catheter.
Maybe anger.
Three-way catheter and a washout.
Refer.
Refer to the urologist will be the best step. Okay. This is basically, we'll take it in a simple term, what has happened. There is a trauma to the urethra. Okay. Trauma to the urethra here happened. If you remember from our trauma class, I had discussed more about the trauma to the urethra there. According to the ATLS, what they recommend, whenever there is a trauma to the urethra, get a retrograde urethrogram. But what does OHEM or most of the UK guidelines say? Just refer to the urologist when you have it this time. Okay. Why refer to the urologist? Why not get a retrograde urethrogram? Most of the time, this urologist will come and give a trial of Foley's catheterization. If they're able to catheterize using a Foley's catheter, then nothing needs to be done for this patient. If they're not able to catheterize, that's when they'll think about retrograde urethrogram and treat this patient. So sometimes urologists go ahead and do a trial of Foley's catheter. So just involve the urologist, let them take a call. You are not doing anything. If the same patient comes with acute urinary retention, then suprapubic catheterization will become the most appropriate answer here. Okay, as it is not mentioned anywhere or is not suggestive of an acute urinary retention, so we are not choosing suprapubic catheterization. Foley's catheter as an emergency physician, you will not insert because you're suspecting an urethral injury. Retrograde urethrogram, according to US guidelines, yes, you need to get it done. But UK, we usually prefer referring to the urologist because they'll come down and usually give and try of Foley's catheterization. They are doing it. We are not doing it. We are just document that urologist has been informed and case has been taken over by the urologist. Okay, any questions, any doubts regarding this question? Which one of the following drugs causes priapism?
Fluoxetine.
Fluoxetine.
Fluoxetine is the drug known to cause priapism. You need to be aware of. We have an elderly female who does frequent self-catheterization. Okay, why they are not given? Now has come to the emergency department with dysuria and suprapubic pain. Urine analysis shows hematuria. So what is the likely diagnosis here?
UTI.
UTI is upper urinary tract infection.
Bladder CA, bladder calculations.
Bladder CA.
So basically, we'll break down this question. This question most likely it looks like a cystitis. Cystitis is nothing but lower urinary tract infection. Okay. Another one differential diagnosis is even a bladder calculi can present similarly. A calculi which is in the bladder can cause painful urination and can cause hematuria. So bladder calculi is also one of the differential diagnosis here. As cystitis is not given, it looks more like a cystitis because of the self-catheterization. As it is not given, we'll go ahead and choose bladder calculi as the right answer here. If in your exam, if they mention as cystitis or lower urinary tract infection, choose that one. Because of self-catheterization, chances of infection are much more than chances of having a calculi. It becomes more appropriate answer. This is mainly upper urinary tract infection. We're not talking about pyelonephritis. Pyelonephritis, we know it has a loin pain. Nowhere here they have suggested of a loin pain. It is a suprapubic pain, which is classical presentation of a cystitis. Okay. So having closer look, we feel that most likely they might have given a cystitis or lower urinary tract infection as one of the options.
This patient, elderly female, will not suspect bladder CA.
I don't know how you.
Bladder CA will not present with some dysuria or suprapubic pain. Usually will not be seen.
Yes.
Sir, bladder CA won't cause dysuria, no, sir.
Sorry?
Bladder calculi, it won't cause normal dysuria as not like uteric calculi, no, sir.
It can cause painful urination if it is at the, sorry, what we call it?
Saigon.
Yes, if it is somewhere here, near the urethral, this urethral sphincter, near the sphincter, it can cause painful urination. So it is a bladder, this is a bladder, if this is a urethra, if somewhere is here, it can cause painful urination. So what we are suspecting is one of the options inside of UTI, it might have been lower urinary tract infection. Then you are choosing lower urinary tract infection because everything goes in favor of lower urinary tract infection. But with the options of this, we are selecting bladder calculi as the right option.
Sorry, Doctor Amin, but urinary tract infection, I think, is most probably because it is the urinary tract infection. They didn't tell upper or lower. So
Or
it
lower,
includes both.
yes.
It can
And also
include both.
frequent self-catheterization. This is point.
Self-catheterization, this is indication of UTI.
We are
this is a cause
not
of UTI.
sure whether they had given as an upper urinary tract infection or a lower urinary tract infection or as an
This is
urinary
in
tract.
general, UTI. UTI is called for the upper and lower.
Okay.
And the point of frequent self-catheterization.
Yeah.
See, I'm telling you again, we are not sure what was exactly given in the option. If they're given as an upper urinary tract infection, it will be wrong. If they are given lower urinary tract infection, it is correct. If they are just given urinary tract infection, that will be correct. If they are just given as an cystitis, that will be the correct option. If they are not given any one of this following, we recommend you to select the bladder calculi. Again, have a look in the examination. Doesn't mean that I have told bladder calculi, you go blindly and select bladder calculi. I'm stressing it, most likely it is cystitis with the history what they have given. Have a look at the options what they are given. They can change the options at any point of time. Choose accordingly.
well?
And show urine analysis hematuria. يعني more
Amin. Dr. Amin, can you hear me
Hematuria
well?
can be there in infection, can be there in a calculi, can be there in a CA, can be there in schistosomiasis also.
Dr. Amin, can you hear me well?
Yes.
Yeah.
So this is a last.
You know, this question, I think, yes, bladder calculi because of frequent self-catheterization. That means there is lodgement and dislodgement of the calculus that close the urinary outflow from the bladder, along with hematuria.
Unlikely to be and calculate. Most appropriate diagnosis here will be infection because of self-catheterization, and with the symptoms what they are given, the infection should be an cystitis. That is bladder infection what you're talking about. That is nothing but lower urinary tract infection. Okay, if they are given any of these options, select that one. If they're not given, if they're given bladder calculi, then you can select as in bladder calculi as the second best option, depending on the what options they have given.
This is the last direct exam, April, no, sir. What is the answer given?
We are not sure about the options. If you can give me exactly options, I can tell you the answer exactly. That's why we're giving you the explanation. Accordingly, you choose it. So going for the next one, a 17 years old male came to the emergency department with testicular pain. On the examination, blue dot sign was positive. This time they didn't give you the image. Still, if they are mentioned as blue dot sign is positive, you're choosing torsion of hydridity form of is the right answer.
Yes.
A young male presented to the emergency department with a history of sickle cell disease and has an priapism was the next best step here in the management. Again, aspirate blood with a needle. C is the right answer here. Elderly male treated for a lower urinary tract infection twice in a month and now he has come back complaining of pain on defecation. Again, we advise you to select prostatitis. All three questions were the recall questions which have appeared previously in the examination, in the previous diet examination. So anyone has any questions, you can ask me now.
Dr. Amin, regarding urethral fracture, there is a question in the MRCM exam prep, say that you do the retrograde urethrogram. The correct question is that. Is correct or not?
As we explained, choose urology reference as the right one. You can go ahead and check in your Oxford handbook. It is clearly mentioned involve the urologist. So we are going with the guidelines what's given by the UK. OHM is in UK book. So we are going according to the UK book.
Okay.
Excuse me, Dr. Amin.
Yes, please.
Can I check the second questions, please, for the bill clamper deformity? And how does the question will come for this topic, please? The second question, I think.
Which, this one?
The bill clamper, the second one on the recalls.
This has already been explained during the chapter
Yes.
urology while we are
No, I
suspecting.
want the question itself. I want the questions, please. Yeah. I want to check the question. Yes. 12 years old. Yes.
Anyone has any doubts, you can ask me.
Thank you very much.
Thank you, sir.
Okay, we'll stop the class here. Thank you, everyone.
Thank you very much.